do my introductory stuff before we meet the committee. So welcome to this morning's hearing on the Committee on Health and Human Services. If you're listening on audio, there's also a visual presentation that you can catch on the YouTube channel for this particular committee. And you can get that by going to the main legislative website. Everything is recorded, including as soon as attendees join us as participants or panelists. So I just want to remind everybody that everything is recorded. So again, to those of you who weren't here yesterday, we're learning this technology and we ask for your indulgence, your patience. We learned a lot yesterday and hopefully we'll learn less today. But thank you for bearing with us while we sort this out. For the committee members, I'd ask that you keep your mic turned off, remain as visible as possible. This is my reminder to turn off my cell phone so that I don't get dinged. And also as a reminder that we cannot put anything of any significance, any content in the chat box. That's just for the mechanics of the hearing. So we'll be hearing the bills today in numerical order, the way they're published. We'll start with 17 and then hear LD 166. And this afternoon, we'll hear LD 24 and then 47 to let people know about that. If you're testifying, please make sure that what is under your name accurately reflects your name. That'll make a difference for those of us who are trying to manage the meeting. And after you're done with your testimony, if you could excuse yourself and go into the YouTube viewing mode and out of the committee hearing specifically, that would be a big help. Reminder that written testimony that hasn't been submitted yet can be submitted anytime. We're always glad to get contributions. And I will let you know that to begin with some of the bills, we allow 5 minutes for the sponsor or any complicated explanations. But other than that, we're sticking with a 3-minute clock, given the amount of interest in the bills that we'll be hearing. So we've been instructed to stay in the gallery view as much as possible. And unless there's something else, I'll ask the committee to introduce themselves, starting with Representative Zager.
Thank you, Mr. Chair. Good morning, everyone. Sam Zager, District 41, parts of Portland.
And Representative Lemelin.
Good morning. I'm Michael Lemelin. I represent District 88, Chelsea, Jefferson, Whitefield, and half of Noblesboro.
Representative Perry.
Good morning. I'm Representative Perry. I represent House District 140, which includes Indian Township, Baileyville, Barron, Calais, Charlotte, Robbinston, Perry, Pembroke, and Pleasant Point.
Representative Griffin.
Good morning. My name is Abigail Griffin, and I represent House District 102, which is Glumber, Levant, and Cadescate.
Representative Connor.
Thank you, Mr. Chair. My name is John Connor. I represent House District 58, which is part of Lewiston.
And Representative Craven.
Thank you, Mr. Chair. Good morning. I'm Margaret Craven, and I represent House District 59, which is part of Lewiston.
Senator Moore.
Good morning. This is Marianne Moore, and I represent Senate District 6, which is all of Washington County, as well as Goldsboro, Winter Harbor, and Sullivan in Hancock County as well.
Representative Meyer, one of our co-chairs.
Thank you, Mr. Chair. Good morning and welcome to those joining us today. I am Representative Michelle Meyer, serving Southern Maine's House District 2, which is Elliott, and parts of Kittery and South Berwick.
And welcome all. My name is Ned Claxton. I'm the Senate Chair for the Health and Human Services Committee, and I represent the folks in Senate District 20, which is Auburn, Minot, Mechanic Falls, Poland, and New Gloucester. We're joined by two important staffers for the committee today. Anna, would you care to introduce yourself?
Hi, I'm Anna Broom, and I am a legislative analyst in the Office of Policy and Legal Analysis, one of the nonpartisan staff. And I just also want to let you know while I'm here that for both of the bills that you are hearing this morning, there is no current law online, but there are fiscal notes for both of them.
Thank you very much. And just for the record, I refer to her as Anna at her request, and she didn't tolerate Ms. Vroom. And so we also have our clerk with us, Carrie Withy.
Good morning. My name is Carrie Withy, and I'm the clerk for the Health and Human Services Committee.
Okay, so with the introductions done, we're in a place to start hearing bills. We'll start with LD 17 and ask that we include the sponsor, the prime sponsor.
I'm promoting Senator Maxman now.
Thank you very much. Good morning, Senator Maxman, and welcome.
Good morning. Let me pull up my testimony right here. Senator Claxton, Representative Meyer, and honorable members of the Health and Human Services Committee. My name is Chloe Maxman. I represent Senate District 13, which is all of Lincoln County except for Dresden plus Washington and Windsor, a total of 27 towns. Thank you for the opportunity to speak in support of LD 17 to provide rural non-medical transportation services to elderly and adults with disabilities receiving home and community benefits under the Main Care program. This bill reflects nearly 3 years of work, and I'm very excited for its potential. LD 17 is built to address the deep need for transportation access, especially for rural communities. A report from the Transportation for America, which is the largest, most diverse coalition working on transportation reform, found that seniors age 65 and older who no longer drive make 15% fewer trips to the doctor, 59% fewer trips to shop or eat, and 65% fewer trips to visit friends and family. In the 2016 Shared Community Needs Health Assessment for Lincoln County, transportation is one of the biggest health factors leading to poor health outcomes in our community. So what if you can't afford a car or you can't drive? Regional programs have emerged, but many are volunteer run or require funding that is going dry. This pattern became hyper clear to me when COVID hit. All the ride services shut down in my area, and I ended up running a transportation network to bring folks to doctor's appointments, pharmacy pickups, a grocery store, and other essential stops. This network continues to this day, organize multiple rides a week for people in my region because there is simply no other option. It's time to search for solutions to this very complicated matter, and please bear with me as I walk through my thought process on this, as it's key to understanding why this bill represents a possible path forward. At first, I had thought of an Uber-like application, but there are major gaps in internet and phone service in communities like mine. There are also hurdles for folks to learn the technology to access these services. I considered, more rural bus routes, but how do you get to a bus route if you don't have a car? How do you get the word out about these new services, and how do you make it cost effective? So this bill seeks a solution inside an existing infrastructure, which is Main Care. Main Care already provides members with access to medical transportation, but this service currently does not extend to non-medical basic needs outings. LD 17 serves the purpose of expanding transportation access in a model that would work for rural places, directly serving populations that need it most and reducing costs. I first introduced LD 17 last session, but it died when we adjourned because of COVID. The committee was divided on whether to do more research on this issue or implement a pilot project. I think enough research has been done on this issue, both by stakeholders and DHHS. It is time to figure out a solution to a problem that we know is hurting Mainers every single day. LD 17 is inspired by a model from New York that would provide a stipend to members for non-medical transportation means, if they have no other means of transportation, to use as they need for basic needs outings. This pilot project would serve Section 19 Main Care recipients, which includes seniors and adults with disabilities that would otherwise qualify for a nursing home level of care. It also directs DHHS to assess the effectiveness of this project in 2023. As you will hear, DHHS can implement this as a state-funded program. You will also hear that Motive Care, formerly Logisticare, is also in support of this project. In other words, this is a very feasible path forward. Thank you very much for your time and consideration today. Transportation is truly the great and necessary equalizer in rural Maine, and I think that this bill offers a promising path forward. I am happy to answer any questions.
Thank you, Senator Maxim. Are there folks who have questions for the senator about her bill LD 17? Yes, Representative Craven.
Thank you, Mr. Chair. Thank you, Senator, for reintroducing the bill. I'm a big supporter. So do you know, have you talked to the department about whether or not Medicaid would actually reimburse for this program? Because there was a day when it actually did, and wondered whether the rules changed enough not to allow that to be reintroduced.
The department's testimony will best answer your question, Representative Craven, but the testimony that I saw did say that some of the rules would have to be changed, but that it was very feasible and that they would be able to implement the project.
Representative Connor, you had a question.
Yes, thank you, Mr. Chair, and thank you, Senator, for bringing this to our attention. I have what could be considered 4 questions, but they're kind of all interrelated, if you will allow me, Mr. Chair.
Please.
So, Senator Maxim, can you define rural for purposes of this particular bill?
So the only parameter around the project is that it would serve Section 19 recipients. And so some of those folks are going to live in urban centers and some in rural, but the idea is that the model is one that could work for rural communities. So it can pick people up at their homes. It's not a fixed route schedule, and other key things that do not exist in rural communities right now.
So any member that's eligible for Section 19 benefits will be able to participate in this program, even though the title is clearly rural.
Yes, and
Okay.
and Section 18 recipients can only participate if they have no other means of transportation outside of the medical transportation already provided.
I thank you for that, because you segued into my very next question, which was, can you define no other means of transportation? What does that mean? If a person, like you said, is in an urban area and there is public transportation available, is this benefit still able to be utilized by those folks?
As you'll see in the bill, the language is broad because these details need to be worked out, and that is something that I would leave to DHHS. And so I think that needs to be defined. I also think that, I would be very much in support of being able to track the money, so it would be giving each member $2,000, and we would want to be able to make sure that that money wasn't being used irresponsibly. And so I think these are the details that need to be worked out, but that is best done through the DHHS process.
Thank you. We must be on the same page, because you're segueing right into my very next question, which was the bill language states that individuals may receive up to $2,000 in non-medical transportation services being the focus of my attention. So is the intention of the bill to just give people $2,000 stipend to use however they want, however they can use it? Or is the intention to provide state funded transportation to these individuals?
Both, so the idea would be that if folks are in a community where they don't have transportation access, but there's a taxi service or some kind of other service that kind of exist where I live, that they could use the money for that. They could get a ride through Logisticare if that worked for them. But the idea is that for a lot of folks right now, that the Logisticare model is necessary but not sufficient to fulfill all of their needs. And so this gives people more flexibility. And again, I would emphasize that this is a pilot project. This is an effort at trying to figure out a different way to provide transportation to folks who are basically homebound.
Absolutely, I agree. I just wanted to make sure that I'm clear on all of the terminology. So that's all the questions I have, Mr. Chairman. Senator, I appreciate you answering my questions. Thank you.
Thank you, Representative Connor. Are there other questions for Senator Maxman? I don't see any, so we'll begin to call other folks who'd like to testify. So thank you for being here and introducing the bill.
Thank you.
Representative Connor, if I don't call on you right away, it's because the hand sits right over that bright light and I sometimes can't see it.
I'm sorry, sir. I will.
No, that's not
I can turn
not
that off
anything
if you
to. I'm learning. I'm learning. That's one of the things I'm learning. So we're joined by several folks who'd like to testify, and we'll start with Adam Zuckerman. Welcome. Good morning.
Great. Thank you for having me. Senator Claxton, Representative Meyer, and honorable members of the Joint Standing Committee on Health and Human Services. My name is Adam Zuckerman, and I'm the lobbyist for Maine People's Alliance. Our 32,000 members stretch from Kittery to Fort Kent. I'm pleased today to testify in favor of Senator Chloe Maxman's LD 17, resolved to provide rural non-medical transportation services to the elderly and adults with disabilities receiving home and community benefits under the Maine Care program. When I was 11 years old, my grandfather was diagnosed with dementia and could no longer drive or live alone. Luckily, he was able to move in with my family in Portland. With 2 cars, my parents were able to drive him to his numerous doctor's appointments, shop for him at the grocery store, and pick up his prescriptions. Unfortunately, many seniors and people with disabilities are not privileged to have such ample and easy access to transportation. Many in our state, the most rural in the nation, live in areas without any public transportation. Transportation is a lifeline for seniors and people with disabilities. You can't stay healthy if you can't get to the doctor or fill your prescriptions at the local pharmacy. For many Maine seniors and people with disabilities, tasks like these can be next to impossible without access to safe and reliable transportation. No one should be denied access to care simply because they don't have the means to transport themselves. Over the past months in quarantine, many of us have gained a new appreciation for how hard it can be to feel isolated. For many seniors and people with disabilities, without access to transportation, that isolation started long before COVID. Yes, LD 17 is about access to groceries and medicine, but it is far more than that. It is also making our communities whole. It is about allowing everyone to participate in our society, about not casting aside the elderly and disabled. Last session, this bill came out with a divided report. Some expressed a need for more research. However, the Department of Health and Human Services has already done that work. They support this pilot program. I do as well, and would encourage this committee to support this crucial lifeline for Maine seniors and people with disabilities. Thank you.
Thank you, Mr. Zuckerman. Does anybody have any questions for Mr. Zuckerman? I don't see any, so thank you for being here. And then before we proceed to the next person offering testimony, I'd like to give Representative Stover a chance to introduce herself after she unmutes.
Who did he say?
Here we go.
Okay.
Didn't want to unmute. Good morning.
Who
I
did?
apologize for late. My name is Holly Stover, and I represent House District 89, including the towns of Boothbay, Boothbay Harbor, Southport, Edgecombe, Westport Island, and part of South Bristol. Thank you.
Thank you. The next person offering testimony, we were joined by Dorothy Treadwell. Welcome. And go right ahead.
Good morning, Senator Claxton, Representative Meyer, and honorable members of the committee. My name is Dorothy Treadwell. I am a resident of Auburn, and I'm here today to testify for LD 17. I have relied on Maine Care transportation for many years to get to doctor's appointments. Having one service for all my health needs would be awesome. Right now, I have to ask my daughter to go to the store for me. Sometimes it's a week or more before she can go. If she forgets something, I might have to wait a week or 2 longer. Most of my prescriptions can be delivered by local pharmacy, but my diabetes kit comes from CVS. My daughter has to get that for me. Sometimes I have to wait. This morning, my pharmacy called to say that they wouldn't be able to deliver my shingles vaccine in time for my doctor's appointment this afternoon. They asked if I could stop by.
Ms. Treadwell, we're having
Pharmacy,
trouble. We're having trouble with
on
your
my
link.
way. Don't do that.
Ms. Treadwell,
What
Ms.
is
Tread-
that?
Ms.
Yes.
Can you close down your video? We're having trouble hearing you consistently, and if you shut down the video, we might be able to fully hear what you have to say. Thank you.
Okay. Do you want me to start over?
No, I think if you go back a sentence or two, and that'll work fine.
Okay. Well, I said that I have to wait for my medication, my diabetes kit from CVS. And this morning, my pharmacy called to say they wouldn't be able to deliver my shingles medication in time for my doctor's appointment this afternoon. They asked if I could stop by the pharmacy on the way to my appointment. And I said, no, I can't because Logisticare won't do that. Like many people who rely on Logisticare, I'm frustrated with the entire system. It seems to be based on demeaning people who rely on it. It doesn't seem to be about promoting health at all. Just last month, I called at 4 p.m.
So,
on
Ms.
a
Treadwell, is this about the bill that you're supporting, or are you concerned about Logisticare? Because we really need to hear about how the bill would be helpful to you, and less, I think, about Logisticare, Modicare.
Okay.
Thank you.
Okay, so we need a transport system that promotes health and human dignity. I want to know that when the system isn't working for me, someone will listen to me and do something about LD 17, would ensure that seniors and disabled people like me are able to access what we need when we need it. I hope you will vote to advance this bill.
Thank you, Ms. Treadwell, and I apologize for interrupting you. We wanted to make sure we heard your message and that it was focused on the bill. So thank you for being here this morning and taking the time to testify. Are there any questions for Ms. Treadwell? I don't see any. So thank you and have a good rest of the day.
Okay, thank you so much.
Next, we're going to hear from Jess Maurer. Welcome.
Thank you so much, Senator Claxton, Representative Meyer, and members of the Joint Standing Committee on Health and Human Services. My name is Jess Maurer, and I am the Executive Director of the Maine Council on Aging. I am testifying in favor of both LD 17 and 166, but because we're the lead organization promoting LD 17, I'm going to keep my remarks generally to that bill. In order to stay healthy, as you've already heard, we need reliable and consistent access to employment, financial resources, healthy food, exercise, and socialization. And as we are becoming very clearly aware, socialization is especially critical in relation to social isolation, which is now associated with increased rates of falls, coronary heart disease, stroke, suicide, and depression. It's also been suggested that social isolation is akin to smoking a pack of cigarettes, I think, a day, which is a little bit crazy. But ultimately, this makes transportation, when you don't have it, one of the core social determinants of health. 72% of older Mainers live in communities without access to fixed route transportation or flex route transportation. And that means that older adults who are living in those communities, when they can no longer drive for whatever reason, they are reliant on other people to get to medical appointments, the grocery store, social activities, the bank, places of faith and worship. Thus, enabling older people to access transportation when they can no longer drive, it becomes a critical component to ensuring that they maintain good health. Currently, under Maine Care Section 19, the home and community-based benefits for elder and disabilities provides only non-emergency medical transportation to the members. The Centers for Medicare and Medicaid Services does allow non-medical transportation to be offered to participants to enable them to gain access to, and it's quote, community services, activities, and resources as specified in their service plan. Under the current system, the service plans of multiple people under Section 19 do include an indication that they need transportation services that are not to doctor's appointments, but are for other social determinants of health, like getting to the grocery store, getting to the dentist, which is not covered by main care, getting to the podiatrist, which is a critical, foot care is critically important for many older people. And so what this bill proposes to do is really to require the department to take advantage of these allowable provisions by directing it to do an 18-month pilot project that allows people under Section 19 to receive up to $2,000 to be used for non-medical transportation services as specified in that person's service plan. I want to note that, yep, I've got 6 more. I just wanted to call your attention to Betsy Sawyer Manter's testimony that has been submitted. She was not able to provide testimony in person today, but one of her organization, EIM, is a care coordination organization, and she's provided specific details related to the lack of services in people in Section 19. Thank you. I'm happy to answer questions.
Thank you for that testimony. Are there any questions from the committee? I don't see any right now, Ms. Maurer. Appreciate your testimony. Thanks for being here.
I did set my clock too this time. Sorry about that.
I wondered where that came from. So we can't find you the $5 for having your alarm go off. Okay.
No, I can't see the clock, so I do it my own.
Okay.
You know.
Timing, yeah.
Well done. Well done.
Good job.
So the next several folks are in the meeting to testify. So we welcome Joseph Kubetz. So I apologize if I've got the last name wrong.
Good morning. That was excellent. Thank you. Thank you, everyone, for being here. Just going to prepare my testimony here. Just one moment. So good morning, Senator Claxton, Representative Meyer, honorable members of the Health and Human Services Committee. Thank you for being here and holding this session. My name is Joe Kubetz of Portland, and I'd like to offer my support to LD 17, the non-medical transportation bill. I'm very much in favor of this bill. I'd like to begin by posing a very simple question. Have you ever been without transportation? Have you ever been without a car or a ride? From my own experiences, it can be challenging to get by when our wheels, our vehicle, are not working. All of a sudden, we cannot get milk or toilet paper, a pharmacy prescription filled, and the list could go on and on. So this bill is called the Non-Medical Transportation Bill, but I've heard someone term this health and wellness transportation. This is an important factor to understand. This bill would help keep people well, which is important in and of itself. It might also keep bigger, more challenging issues at bay by keeping these same fellow Mainers well and healthy and connected to the resources and support that they need. This important bill would also work to restore the viability and reliability of this transportation system for Mainers who depend upon it. The ride system changed approximately 8 years ago, and it lost its reliability. We need to restore that reliability for people who are counting on it. I'd like to add 3 brief footnotes to my testimony. Briefly, a history of this kind of transportation is years ago, we would not cover a ride to a doctor's appointment, but we would cover a ride for an emergency room visit. And we changed that system years ago because we realized that helping someone manage, for example, their diabetes care through a trip to the doctor's office not only kept them healthy, but it also could save money, because when diabetes goes bad because someone can't get to their doctor, it actually costs a lot more. And I think, as other testifiers have mentioned, getting to the grocery store, staying connected to their neighbors is something that's going to help people stay well, and could also save us money. I think we can all think of people who might rely on this system. I have a 73-year-old older friend that I know who certainly would benefit from this and has had to hobble from the pharmacy to the grocery
30
store,
seconds, Mr. Kovitz.
for instance. And if I could just have a brief extension.
30 seconds. Is that
Thank
enough?
you. So 73-year-old man who I know, who's a great guy, retired postal worker, hobbling to try and get to the grocery store. And just in support of Ms. Treadwell's testimony, I think what she is mentioning is that this bill also provides for a study of the effectiveness of the ride service in the pilot program. So I think that's what Ms. Treadwell was speaking of, was that it will also study that the ride service actually works, which is important for people who depend on it. So thank you very much for your time and consideration. Really appreciate it. Thank you for being here.
Thank you for taking the time to be here to testify. Are there questions from the committee? I don't see any right now, but thank you very much. So now we'll move to Mallory Shaughnessy.
Hello, good morning, Senator Claxton, Representative Meyer, members of the Joint Standing Committee on Health and Human Services. My name is Mallory Shaughnessy. I'm a resident of Westbrook and the Executive Director of the Alliance for Addiction and Mental Health Services. The Alliance is the statewide association representing the majority of Maine's safety net community-based mental health and substance use treatment providers. The Alliance advocates for the implementation of sound policies and evidence-based practices to serve to enhance the quality and effectiveness of our behavioral health system. On behalf of the Alliance, I am here today to speak neither for nor against LD 17, but to share some thoughts about another vulnerable sector of the population receiving main care services that have a real need for non-medical transportation services. Children that are being treated in residential facilities and their families that cannot find a way to see them nor participate in the needed family meetings and treatment planning. We agree that access to transportation is limited for many across Maine, especially in rural areas of our state. And then we also face barriers to transportation in urban areas, depending on where they're trying to get to and from. We believe this pilot would be a great step forward, but would like to see this pilot expanded to include a population that is severely impacted when they do not have access to transportation. Children covered under Chapter 101 Main Care Benefits Manual, Chapter 2, Section 97, Appendix D, Child Care Facilities and their families. In 2019, we testified in support of LD 1062, an act to support Maine families by providing for transportation of parents and guardians to Maine care recipients under 18 years of age to their appointments, sponsored by Representative Colleen Madigan. We know there are many family meetings that occur when a child is receiving treatment in a residential mental health facility, meetings in which the family or guardian should be present in order to work with the therapist and assist in planning for a return home or for understanding therapeutic interventions and the needs of the child. Transportation for these meetings is not a covered transportation service. The Alliance members feel that this vulnerable population should be included in a pilot. And we thank you for your consideration, and I'd be happy to answer any questions.
Thank you for your testimony. Any questions from Ms. Shaughnessy? I don't see any, so thank you again for being here.
Thank you. And I did try to upload my testimony, but it wouldn't go through the portal. So I'm going to send it over to Carrie and have it distributed to you. Sorry about that.
Thank you for trying. One of the bugs that's being worked out.
Thanks.
We're also joined by Marilyn Cheney. It's your turn to testify when you unmute. Welcome.
Thank you. Thank you for all that you're doing. I'm totally new to this and I'm just want to weigh in. I've had a couple of opportunities in Lincoln County to drive people who are housebound. And I just want to say what a moving experience it is to be able to be so useful to people, but also what a difference it makes to people to be able to just get to Hannaford and to get to the pharmacy on time and to be able to feel that they can rest for the rest of the week until there's another opportunity for me to help. So I do my little bit here in Lincoln County. I live in Waldoboro and it's very remote out here. I think this bill would just be fantastic. So I support it and I thank you for offering such great thought and consideration to this. Thanks very much.
Thank you for participating. And this is what we try and do with all the bills. And we're glad to hear folks who have not testified before join us. So we're also joined by, I don't see any questions. We're also joined by Megan. I can't see well enough. Olney? Alan, sorry about that.
Good morning. Okay. Good morning, Senator Claxton, representatives, Representative Meyer, Joint Standing Committee on Health and Human Services. My name is Megan Allen. I'm a resident of Old Orchard Beach, and I'm here to testify in favor of LD 17. My testimony will sound very similar to those that you've already heard. And again, it's crucial for seniors and people with disabilities to be able to get to their doctors, pharmacists, grocery stores. LD 17 would improve our transportation infrastructure. It would provide a lifeline for these individuals, and it would create employment opportunities for Mainers as well. I'm here to share a personal story and to speak on behalf of my best friend who's no longer with us. When the state's Medicaid transportation system was privatized, many recipients of these services found themselves quite literally out in the cold. Previously, the service was operated by regional transportation providers reimbursed by the state. But by the time my best friend was in the position to use these services, that system had been overturned, replaced with a brokerage system that was more or less fraught with flaws. In 2015, my best friend and I moved into an apartment in Portland together. She was physically disabled, and though I provided many caretaking responsibilities, my vehicle couldn't support all of her equipment. So she depended on these transportation systems that I speak to now. And more times than I can count, I would have to leave work or school and return home and bring her back into the apartment from the curbside. The rides didn't come. They would come well after her scheduled appointments. And as a result, health complications would arise. She couldn't get her medications filled. She would have catheters that were supposed to be replaced and they would get infected. So late night 911 calls quickly replaced routine care, and symptoms and health issues went unaddressed. So my question is, how much does it cost for an ambulance to respond to a situation, especially one that could have been avoided? Hopefully not the cost of another life or a critical situation, because paramedics would have been preoccupied responding to a call that ultimately shouldn't have been placed to begin with. And I've read and listened to grievances of many others whose experiences with this system now are just as formidable, but those stories aren't mine to tell. I will note that many of the individuals, however, live in communities where resources are more plentiful. So I can't imagine what the experiences are for those rural Mainers who depend on these transportation services. The research has
30
been
seconds, Ms. Allen.
Thank you. The Department of Health and Human Services has done a great job. They support the pilot program. I support the pilot program. I thank you for soliciting everyday Mainers, hearing our stories, and I'm hopeful that we can resolve this and pass this vital piece of legislation. Thank you.
Thank you for bringing your testimony. Are there any questions? I don't see any. I see we've been joined by Representative Javner. Would you introduce yourself, please?
Thank you, Senator Claxton.
You're going to have to mute yourself, and there we go.
I apologize.
There we go.
I'm Representative Kathy Javner, and I represent House District 141, which is located in Picot and Washington counties.
Okay, the next person testifying is Molly Bogart. Are you here? There she is.
Great, thank you very much. And I'm
reading to you a letter from Director Probert from Maine Care Services and Director Saucier from the Office of Aging and Disability Services. So Senator Claxton, Representative Meyer, members of the committee, thank you for the opportunity to testify on LD 17. We are neither for nor against this bill and are providing some information for your consideration as you discuss. So this resolve requires us, the Department of Health and Human Services, to develop a pilot project lasting 18 months to provide up to $2,000 in non-medical transportation services to each member receiving services pursuant to Section 19, Home and Community Benefits for elderly and adults with disabilities. This resolve also requires us to submit a report regarding the costs, effectiveness, and future viability of the pilot no later than January 30th, 2023. In order to implement the pilot as written under the Section 19 program, it would require both changes to the Section 19 rule and the Section 19 waiver, approval from the Center for Medicare and Medicaid Services, and changes to the service authorization process. In addition, an amendment to Maine Care's non-emergency transportation, or NET 1915B waiver may be necessary if non-medical transportation services covered through this pilot were to overlap with non-medical transportation services already provided through Maine Care's net brokerage system. However, relying on federal funding would make a short-term pilot program more challenging to implement, as CMS generally does not approve pilot projects outside of an 1115 waiver, which requires the state to demonstrate cost neutrality or cost savings. So funding a pilot with state funds would allow more flexibility to prove and disprove the concept. Our estimate assumes using all state funding for a pilot covering approximately 10% of the Section 19 client population. Using all state funds would also alter the regulatory changes that we would need to make. The concept of a defined per person non-medical transportation benefit exists in other states, as you've heard other folks testify to, including New York for behavioral health services. We're in the process of completing an evaluation of our current transportation program, and that evaluation will contain more information about the New York model as well as other transportation models. Current information suggests that a pilot program of this model is certainly worth exploring, provided that adequate funding were available to do so. So through this letter, we wanted to make sure that you had this information. I'm happy to answer questions to the best of my ability now, and will also be able to participate in the work session.
Thank you, Ms. Bogart. You have a question, Representative Zager.
Thank you so much, Mr. Chair, and thank you very much, Ms. Bogart, for coming back. Really appreciate the department's input. So I'm interested in the potential of this this proposal to improve what some sociologists call social infrastructure, and as people have mentioned, the upstream contributors to health. With regard to how the department might structure the pilot, I'm wondering if consideration has been or might be given to doing a randomized trial, as the state of Oregon did when it realized it did not have all the money that it wanted, that it would have needed to expand Medicaid to all the people that it wanted to, but in the hopes that the information gained from that pilot would be more powerful information in terms of the hierarchy of evidence and guiding evidence-based policy solutions in the future.
Yeah, absolutely. Thank you for that question. I think the fiscal estimate that we've provided to OFPR is based on serving the entirety of the waiver, making assumptions around how many people would meet the eligibility criteria, but not having other methods of transportation, et cetera. If the committee and the appropriations committee determined to provide less funding than that, I think we'd certainly be open to considering whether, how we would do a more limited pilot, whether that was a randomized, kind of lottery-like option or not. I think the early getting some understanding of the experiences of Maine recipients will be important. So. But we also know that this is a huge barrier for a number of our clients. So I don't think we'd have any problem sort of right sizing the pilot based on the appropriation that we were provided should this pass.
Okay. Representative Lemelin, you had a question.
Thank you, Senator. Molly, my question is There's no coverage under section 19. Do you know if there's coverage under section 21?
I would have to confirm, although part of the challenge that we have laid out here is that main care or Medicaid does not, under normal circumstances, reimburse for non-medical transportation. And so I think if there are services that are part of someone's plan of care in section 21, there may be opportunities there. I'd have to get more information for you for the work session.
Okay, thank you very much.
Yeah.
Are there other questions? I don't see any. So now we're joined by Pedro Vasquez. Welcome.
Thank you, Senator Claxton, Representative Myers, members of the committee. I am Pedro A. Vasquez. I am the chair of the South Portland Human Rights Commission. Human rights are inherent to all human beings. They're defined and established in more than 80 international legal instruments and include fundamental protections of human dignity, needs, and freedoms, such as food, housing, privacy, personal security, and democratic participation. These, of course, are dependent on an individual's access to transportation. In my professional capacity, I've represented individuals living with disabilities and their families in administrative law proceedings throughout the United States. And in this role, I'm often both a source of support and a confidant to my clients. I hear their struggles and have intimate connection to the obstacles that exist and make their lives difficult. So this lack of reliable transportation is often a structural barrier that prevents people living with disabilities from fully participating in community life. According to the American Association of People with Disabilities, adults with disabilities are twice as likely as those without disabilities to have inadequate transportation. So we're talking about 31% versus 13%. And of the nearly 2 million people with disabilities who never leave their homes, 560,000 of those folks never leave home because of transportation difficulties. So minimal or non-existent transit services in rural areas especially severely curtail the mobility of people with disabilities and keep them from jobs, medical appointments, community life, and independence. Equity in transportation is an important human rights issue. It is critical to the independence of people with disabilities and their ability to contribute economically, socially, and politically. And so in closing, I have to say that it's important that careful attention is applied when crafting this framework for this pilot program in order to avoid replicating some of the exploitative practices that we have seen within the transportation broker model that was previously in use. I encourage you to support LD 17 and am available for questions. Thank you.
Thank you for your testimony. Anybody have any questions? I don't see any. So again, thank you for being here. And now we'll move to Sarah Squan. Is she in the room? I just can't see her. Sarah, if you're there, thank you. Welcome.
Good morning, Senator Claxton, Representative Meyer, and members of the Joint Standing Committee on Health and Human Services. My name is Sarah Squires. I'm the Public Policy Director for Disability Rights Maine, and on behalf of our clients, thank you for the opportunity to appear before you today. As you've heard, the Section 19 waiver provides support services to individuals with disabilities and the elderly who qualify for nursing facility level of care by allowing them to receive services in their homes and communities instead of institutional settings. No secret that transportation is a significant barrier to preventing adults with disabilities from achieving full community inclusion. When individuals with disabilities are isolated, society as a whole suffers a detriment. It is deprived of citizens who can contribute to the greater good. A lack of access to transportation inhibits the ability to be an employee, an employer, a consumer, a volunteer, a friend, a significant other. Access to transportation allows people with disability to be more independent and helps them to avoid or delay institutionalization. Access to transportation that will allow individuals receiving home and community-based services to have full community inclusion isn't just a good idea, it's a federal mandate. The HCBS settings rule requires that all individuals who receive these services have the same access to the community as individuals not receiving services in order to continue receiving federal funding. Transportation is a crucial component of compliance with the settings rule. For the foregoing reason, we support LD 17, which will allow Maine to explore ways to improve transportation to individuals with disabilities who receive home and community-based services. Thank you.
And thank you for your testimony. Are there any questions from Ms. Squires? I don't see any. Thank you again. So we're next joined by Warren Stewart. Welcome, sir.
Good morning.
Good morning. Go right ahead when you're ready.
Okay. Senator Claxton, Representative Meyer, and Joint Standing Committee on Health and Human Services. My name is Warren Stewart. I'm a resident of Millinocket in Penobscot County, and I'm here today to testify in favor of LD 17. As a parent of 2 special needs children who don't drive, this is a must bill for rural Maine. Both of my children have or had case management, which is at one time gave them access to community supports. I apologize. I'm awful nervous.
Take your time, sir. It's all new to all of us.
However, as the state kept taking away access to community sports, our children have no transportation to doctor visits, counseling. They don't have a car or drive. I would literally drive to Old Town to pick up my daughter, drive her to Dover, and then drive her back to Old Town, and then drive myself back to Millinocket. Penquist only reimbursed mileage once she was in the car, so we had to pay for gas to Old Town and coming back from Old Town. We are both retired, and that's an expense that we really can't afford. Our daughter also has a service dog that would keep her calm, relax her, and the dog would take her to a quiet place when she had high anxiety or went into a seizure by placing his body across her lap. But when she tried to take her dog on an appointment, she was ridiculed and embarrassed by the bus driver, even though she had paperwork showing the dog was a trained service dog and that he performed many services for her. She has not ridden that bus since. She would also call us when she needed groceries. So would drive to take her shopping and any other place she needed to go. We had workers for her to help with things like this. But again, she needed her dog to keep her calm long enough to do her shopping. And some of the workers would go shopping for themselves before picking her up or take her shopping. Due to the fact that the workers knew her situation and that she had to take her dog for her anxiety and etc., they would still go shopping for themselves and tell her that the dog couldn't go. So she would not get her food, clothing, and etc. that she needed unless we took her. My son is much easier, as he still lives with us. And we take him to travel wherever he has to go. As you can see, we are getting older, we are retired, and it would be a great relief to people who are disabled to have services to go to where they need to go. I thank you.
And thank you for your testimony, sir. Hopefully the next time won't be quite as nerve-wracking.
It probably
You made it. You made it. Are there any questions of Mr. Stewart? I don't see any. Thank you again for being here. I'm glad you could testify.
Thank you.
And we also have Megan Hannon has joined us.
Good morning, Senator Claxton, Representative Meyer, ladies and gentlemen of the Joint Committee on Health and Human Services. I'm Megan Hannon. I'm the Executive Director of Maine Community Action Partnership, or MECAP for short, and we support LD 17. MECAP is the association of the 10 community action agencies in Maine, 2 of which are transportation brokers, and 6 are regional transportation providers. All provide transportation for older adults and people with disabilities. We know firsthand the need for non-medical transit services for elder and adults with disabilities is high, which is why we wanted to weigh in and support this. Addressing non-medical transit needs for those who have no ability to transport themselves can help address issues such as social isolation, poor nutrition, and related health issues that arise when isolated elders and adults with disabilities cannot regularly shop for groceries or prescription medication. Food, of course, is also medication. Current non-emergency medical transportation, arranged by one of the three brokers, is a system that has a finite capacity and is designed to respond to main care members' medical needs. We believe that introducing a significant volume of non-medical trip requests in the current system may strain that system and may disrupt reliable and predictable transportation services that chronically ill main care members rely on, those who use dialysis or chemotherapy, for example. Therefore, as we move forward with this, we recommend implementing this service by directly engaging the current designated regional transit providers, as this would be the most efficient and cost-effective way to implement this 18-month pilot program. I'm happy to answer any questions that I can now or for the work session. And I just want to say to Mr. Stewart, I will look into the situation of your daughter's service dog. If that was a Penquist driver, and we will respond to that. Thank you very much.
Thank you, Ms. Hannon. Are there any questions before we proceed? So one of the things we learned yesterday was that sometimes people sign up late and want to get in, but we're not aware of them. So I'm going to suggest we take a 5-minute break and ask anybody who's out there who would like to testify to get in touch with our clerk and express your interest in testifying. So if everybody's okay in that, we'll be back in 6 minutes. Thank you. Okay, we'll review where we stand. And I note that I think we have turned up that we have another person to offer testimony. And so we'd welcome Eric McVeigh to join us. Welcome. We'll be able to hear you as soon as you unmute. Thank you. Go right ahead when you're ready.
Thank you. Yeah, you folks. My name's Eric McVeigh, and I'm from Bangor, Maine. And I'm testifying. I am testifying in support of LD 17. I am testifying in support of LD 17. Yeah.
We can hear you fine, so go right ahead.
Right. And I am testifying in support. What the deal is I had a situation last summer with my day program, and the situation was I was supposed to be done my program. Yeah, my I was supposed to be done my day program at 4:30. My ride did not show up to pick me up until 7 o'clock at night. And so that not only created a bunch of issues, not only for myself, but also my program, because of the fact that when program ends and people are waiting for their rides, staff must be present. And so when somebody is running, when a ride is late, when a ride is running like 3.5 hours late or close to 3 hours late, that means staff ended up having to stay there with me until my ride showed up. And a lot of those folks, a lot of the staff at my program were there at like 7, 8 o'clock in the morning. And luckily the staff that waited with me had gotten there at noontime, so it wasn't quite as bad. But then there was another situation. That arose, that the staff that was when my ride didn't get there till 5:30, and the staff
So, Mr. McVeigh, do I understand you're having trouble with getting reliable service? Is that the big issue
Yes.
for you? Okay. So
Yes.
you've given a couple examples of that. I think you've accomplished that portion. Is there anything else that you wanted to share with us before we move on?
All I can say, that's one of the main reasons why I'm supporting LD 17.
Thank you for your testimony and thanks for making those points. We'll include that in our thinking as we get to our work session down the road. So thank you for taking the time to testify. All right, I don't see anybody else listed testifying on LD 17. So we can move now to whoever's going to introduce LD 166 and take testimony on that. LD 166 is an act to allow participants in the qualified Medicare beneficiary program to qualify for the main care transportation services. I see we're joined by Senator Pouliot.
Yeah, maybe here. Fifth time's a charm, I guess. How's it going, guys?
Thank you. Welcome.
Good morning, Senator Claxton. It's great to see you. And I'm just trying to pull up my testimony here. I'm calling you from my truck. Sorry about this. I had it and it went away.
And for the record, the trees I see through the window are not moving, so you're not.
No, I am stationary and full compliance, parked in a parking lot in a striped spot. Thank God for Wi-Fi in my truck. All right, so bear with me here, guys. Sorry about this.
While you're looking that up, I should officially close the end of the hearing on LD 17 by rapping my knuckles on my desk. And now we'll convene a new hearing, a new public hearing on LD 166.
Great. Good morning again, Senator Claxton, Representative Meyer, and members of the Joint Standing Committee on Health and Human Services. I'm State Senator Matt Pouliot, and I proudly represent the towns of Augusta, China, Oakland, Sydney, and Vassalboro. And I'm here to present LD 166, an act to allow participants in qualified Medicare beneficiary programs to qualify for main care transportation services. This is a constituent request bill. I was reached out to by one of my constituents about an issue that they were having as a qualified Medicare beneficiary, which is a limited benefit, and they don't have full main care. So they did not qualify for non-emergency transportation services. Furthermore, when they reached out, they were told that a statute change would have to occur. And that's when they reached out to me about submitting this legislation. I do think that it's critically important that people are able to make it to their appointments. We hear a lot of times even from providers, folks who are no-shows for appointments, that negatively impacts them, but also doesn't allow the people to get the care that they need. And so certainly being able to make it to these appointments is vital. And unfortunately, a lot of people don't have access to that transportation, as we've heard, or it's not reliable. It does appear that this, after submitting the legislation and was drafted, that OFPR came up with pretty substantial fiscal note, which, given the challenges that we're facing now with the budget, may be problematic should the committee support this and once it gets to appropriations. But I think that this is something that's worthy of our consideration and support when we're deciding how to allocate resources, making sure that those people who don't have access to reliable transportation options are able to make it to their appointments for their health and well-being. So I hope that you'll join me in supporting this initiative. I did reach out to the constituent who had reached out to me previously multiple times, but we were not able to connect with them. So I don't know if she's going to be joining or not, but I do suspect that there are some others testifying in support. It's kind of weird giving testimony, not being able to see who's in the room and where folks are going to be at. But I appreciate your time and happy to answer any questions, though I will preface it by saying this is not my area of expertise in policy.
Thank you for introducing the legislation, and thank you for your persistence in getting hooked up with us. Are there any questions for the senator? Yes, Representative Craven has a question.
Thank you, Mr. Chair. Thank you, Senator, for bringing this forward. Was the person duly eligible for Medicare and Medicare?
They're a qualified Medicare beneficiary. So again, I'm not sure what their status was, but because of that, they were not able to get access to the transportation.
Thank you.
They're not. I guess the better way to answer your question is they were not full main care. I think it might
Well,
fall.
there's a lot of seniors, low-income seniors who have dual eligibility, and they should be able to get, medically needed transportation.
Yeah,
unless they needed, social transportation as well.
It's my understanding from the discussion that she was in the gray area in terms of not being able to qualify because of not being completely on main care.
Maybe Ms. Bogart can answer that when we get to her testimony. Representative Javner, you had a question.
Yes, thank you, Senator Claxton. I appreciate that. Senator Pouliot, maybe actually the department can answer this question, but maybe you know as well. I'm looking at the fiscal impact and it says one-time funding for required technology changes. Do we know can we bring that piece out of the fiscal note? Do you know what that amount is?
I don't, but I do know that the department has weighed in and will be testifying, I believe neither for nor against, with some information about the fact that this would need to primarily come from the general fund and it would not really be federal resources available for this if we head in this direction.
Okay, great,
And I
thank
think
you.
Also too, there seems to be some concerns about access to people that would provide the rides as well. So that might be problematic, but I think worth looking into.
Okay, any other questions for Senator Pouliot? Again, thank you for being here. We'll move on to the folks who'd like to testify. And we may be joined by Jess Maurer, but for now, I think we'll go to Molly Bogart.
Good morning again. My name is Molly Bogart, Director of Government Relations for DHHS. And similarly to the last bill, I'm reading testimony from Director Probert of the Office of Main Care Services. So we are Senator Claxton, Representative Meyer, members of the committee. Thank you for the opportunity to testify on LD 166. As Senator Pouliot mentioned, we are neither for nor against. I wanted to provide you with some context about what this would mean for the department and some of the details of implementation. So this bill would extend non-emergency transportation. Again, we call that NET or NET services, currently available to main care members. It would extend that service currently available to main care members to additional qualified Medicare beneficiaries. We'd be required to submit to the Centers for Medicare and Medicaid Solutions Services any waivers or state plan amendments that are necessary for approval to provide the services. If approval is denied, we'd be required to reimburse main care providers of non-emergency transportation services with general funds. Should this become law, we would be seeking approval to pay for transportation to and from services where Medicare is the primary payer. We do not believe CMS would approve either a state plan amendment or a waiver for these services because under plan authority, the Medicaid program only covers Parts A and B premiums and cost sharing for this population. For waivers, the two options would either be an 1115 demonstration waiver or a 1915B managed care waiver. Under both of those waiver types, we would be required to demonstrate either cost neutrality or cost savings to the Medicaid program, which we don't believe this would be able to achieve. Given these limitations, we would expect that this would all have to be paid for from the general fund. And we also want to note that we are unable to verify that trips were for Medicare covered services as we don't have access to Medicare claims data. Further, the pandemic has resulted in a reduction of available NET drivers. adding additional qualifying members could further stress the limited availability of rides available to existing main care members. So we wanted you to be aware of this information. Again, I'll gladly answer questions within my ability, and also be more than happy to attend the work session. And I can address Representative Javner's question around technology. It looks as though the one-time estimate that we provided to OFPR, that is always subject to change based on discussion with Luke and his team as well as ours, but that looks to be about $16,000. And that is a one-time fee for changing the eligibility software that we use to allow for new functionality.
Thank you for that, Ms. Bogart. Are there other questions for Molly at this point? I don't see any. So thank you for being here.
Great, thank you.
Did we hear back from Jess Maurer at all? Because she'd indicate some interest in testifying. Okay.
I have a couple of missed messages. Maybe we could take another short break and I could just find out if anyone was trying to get on to testify.
Why don't we reconvene in 5 minutes?
Thank you.
Thank you. Okay, so we can resume. It appears that there's nobody else to testify. We'll have to do that as part of our routine in the future. So feel free to remind me if I forget to do that part. So there being no other questions or on this, what kind of questions do we have for our analysts that you'd like to have answered in anticipation of our work session? Anybody have anything they'd like to ask of Anna? On either LD 166 or 17? I don't see any. So I think we're done with that portion. So that concludes the public hearing portion on LD 166. Are there things we need to attend to now, Anna, before we break for lunch? Okay. Any other comments or questions from the committee? Then I'll entertain a motion to adjourn until 1, which is our scheduled next public hearing.
So moved.
Second.
All those in favor? Enjoy lunch. Thank you. Good afternoon, everyone. Looks like we have a quorum. So welcome back with the lunch break. We're now to go into the first of two public hearings this afternoon at the Committee on Health and Human Services. We'll do those in order, starting with LD 24. So before we start, I just want to remind everybody that YouTube is an alternative channel to watch on, audio and visual. Everything we say and do is recorded, so be aware of that. People have been patient with us so far about the things we haven't done as well as we will eventually. So I start there. So for the committee, it's been doing a good job of keeping things on mute and staying visible as much as possible. I haven't heard any phones ringing, and I've reset mine. And a reminder to not do anything not to share any content in the chat that isn't related to committee functioning as opposed to committee content for hearings. So if you're testifying, please correctly identify yourself under your name. I invite the committee to correct themselves too, or we'll let Carrie do it. Then when you're done testifying, if you could go to the YouTube channel and watch the rest of the hearing that you're interested in, you can continue to submit written testimony for as long as we haven't voted on the bill. So that's an invitation to participate that way. Once we're done with the presenters laying out the bill, we'll go to a 3-minute clock, and you'll be getting a verbal heads up at 30 seconds remaining. Hopefully that'll address some concerns. And so for right now, why don't we go around the committee and introduce ourselves, starting with Representative Zager.
Good afternoon, Mr. Chair. Thank you. Good to see everyone. I'm Sam Zager. I'm honored to represent District 41 in Portland.
Representative Lemlin.
Thank you, Senator. My name is Michael Lemlin. I represent District 88, which is Chelsea, Jefferson, Whitefield, and half of Noblesboro.
Representative Perry is here.
Good morning. Oops. Good afternoon. Oh, I'm already off of mute. Excuse me. Yes, I'm Representative Dan Perry from House District 140, and I represent 9 communities along the St. Croix River in Washington County.
And Representative Griffin.
Good afternoon. Am I muted?
Oops, you just unmuted yours. Just muted yours. There you go.
Good afternoon. I'm Abigail Griffin. I represent House District 102, which is Glenburn, Levant, and Cadescate.
Representative Connor.
Good afternoon. Thank you, Mr. Chair. My name is John Connor. I represent House District 58, which is part of Lewiston.
Representative Craven.
Thank you, Mr. Chair. Good afternoon. I'm Margaret Craven, and I represent House District 59, which is part of Lewiston.
Representative Madigan.
Good afternoon. I'm Colleen Madigan. I represent House District 110, which is part of Waterville and part of Oakland.
Senator Moore.
Good afternoon. I'm Mary Ann Moore, and I represent Senate District 6, which is all of Washington County, as well as Goldsboro, Winter Harbor, and Sullivan in Hancock County as well.
Representative Javner.
Thank you, Senator Claxton. I'm Representative Kathy Javner, and I represent House District 141, which is located in Penobscot and Washington County.
Chair Meyer.
Good afternoon, Mr. Chair, and welcome to all of those joining us here this afternoon. I am Representative Michelle Meyer, serving Southern Maine's House District 2, which is Elliott and parts of Kittery and South Berwick.
And I'm Ned Claxton. I represent Senate District 20, which is Auburn, Minot, Mechanic Falls, Poland, and New Gloucester. We're also joined by Carrie Withy, who's our staff person in the clerk role.
Good afternoon. My name is Carrie Withy, and I'm the clerk for the Health and Human Services Committee.
And we're further supported by Erin Dooling.
Good afternoon. My name is Erin Dooling. I'm an analyst with the Office of Policy and Legal Analysis. We don't take positions on or advocate for any legislation. I do want to point out that we'll start before the public hearings, kind of letting you know what's in your virtual files. So for this afternoon's public hearings, for each bill being heard this afternoon, you've received a preliminary fiscal impact statement, and that can be found on our committee materials page under the LD and by clicking on the bill status.
Thank you for that. And I understand that Senator Carney is here to introduce the first bill, LD 24, an act regarding certificates of birth, marriage, and death. And we have a couple people to testify after her. Welcome, Senator Carney.
Thank you very much. It's nice to be here before your committee. I am Ann Carney. I'm here to testify and to introduce LD 24, an act regarding certificates of birth, marriage, and death. Senator Claxton, Representative Meyer, and honorable members of the Health and Human Services Committee. I'm Ann Carney, as I said earlier. I represent Senate District 29, which is the community of South Portland, Cape Elizabeth, and part of Scarborough. This bill, LD 24, fixes some loopholes and updates some language in the laws affecting vital record keeping in Maine. These changes will be useful in streamlining the process of registering births, deaths, and marriages electronically in unincorporated areas, more efficiently updating birth certificates, and clarifying requirements to obtain marriage licenses. I'm sponsoring this bill on behalf of the Department of Health and Human Services. They will provide detailed summary of the changes this bill makes, and I encourage you to direct any changes or questions any questions you may have to them. I'm sorry that I'm a little discombobulated this morning. I apologize to the committee. I'm simultaneously attending another hearing as well. And I do appreciate your consideration of this legislation, and I'm happy to answer any questions you might have, although they may be better directed to the representative from the department.
Does anybody have any questions to torment Senator Carney with? There not being any, we'll thank you for that introduction, allow you to go back to your other committee meeting, and I'll proceed to our next testifier. Thank you.
Thank you. I will try to stay for some of the presentation, and being before your committee is never a torment. Thank you very much.
Also, we're signed up to testify is Ed Pinot. Can you unmute yourself and join us, Mr. Pinot? Oh, I can't hear you. You're still on mute.
You have Kate and not Ed.
Okay, welcome.
I'm not sure, Senator, that this would be the appropriate time for me to speak, since I want to testify neither for nor against.
We are abandoning any concerns about that for right now. We're trying to get through in one piece is our goal.
Well then, I hope I make sense when I thank you, Senator Claxton and Representative Meyer and members of the committee. My name is Kate Pino. I am a resident of Vassalboro, and I'm here today as a contract lobbyist for the Maine funeral directors. We're here to testify neither for nor against. It's our understanding that the language changes in the bill do not change the procedure that our members use when they file death certificates for deaths that take place in unorganized territories. Just to go on for one bit further, what we do is we file the certificate electronically into the electronic system, and the system designates the closest organized township that would be available for a paper copy if the family or the funeral director wants that. So my purpose here today is just to let you know that we are in the room, we're monitoring the bill, and we have no objection. And I'm ready for questions if you have them.
Thank you for that succinct testimony. I see one question from Representative Craven.
Thank you, Mr. Chair. Hi, Kate.
Hello.
So when they're filed electronically and you need one, can somebody just access the file electronically and use it, or does the family have to print it out and lug it over to the bank or whoever it is that needs it?
Good question. There are two ways for a family member or a funeral director to get a paper copy. One is which is to travel to the township, the organized township, or you can request a written copy through the state and they will mail them to you.
But if I'll pick the bank again, if a bank needs a copy, can they just access it electronically?
I don't know the answer to that. I will find out and get that answer for you.
Are there any other questions of the committee? I don't see any, so we'll thank you for your testimony, Ms. Pinot, and we'll see if Kim Hagan has joined us yet.
Good afternoon.
There she is.
Good afternoon. I guess I don't have my video on. And don't see how to put it on. Sorry, I can't figure out how to get the video on, so.
There should be a button at the bottom left that
Yeah.
says stop video with a line through it.
There it
There you
is.
go.
Sorry.
We're all working it out.
Good afternoon, Senator Claxton, Representative Meyer, and members of the Joint Standing of Health and Human Services Committee. My name is Kim Hagan. I'm the Director of Data Research and Vital Statistics and the State Registrar with the Maine CDC. I'm here today to introduce to you and express our support for LD 24, an act regarding certificate of birth, death, and marriage. Maine CDC, Data Research and Vital Statistics, we call ourselves DRVS, DRVS, is responsible for maintaining a centralized statewide system of electronic of vital records and are custodians of vital records from 1892 forward. The office works closely with each municipality to oversee the filing, registration, and amendments of marriages and in issuing all vital records. This bill amends and clarifies languages across several sections of statute that are pertinent to vital records. It corrects a conflict in public law 2019 chapters 82 and 340 by incorporating the changes made from both of those laws into this one law, one section, I'm sorry. 22 MRS section 2703 details how a birth occurring in an unincorporated area is received, recorded, and registered as a vital record. When events occur in an unorganized area, those records are assigned to a municipality in order to be issued. Towns are assigned roles within the system to view and issue the records. When changes were made to the statute in 2011, only births were registered electronically. The registration system has now been expanded to include deaths and marriages, and they're also registered and maintained electronically. Amending the language to include death and marriage registration provides consistency and aligns with the functionality of the electronic registration system in permitting municipalities to issue the record. We do ask that we would like to amend the bill in this 2703 to remove the word birth in reference to electronic birth registration system. And we'd like the new wording to say just registered in the electronic registration system. Another section of this bill allows DRVS to replace the name on a birth certificate of persons 18 years and older when DNA testing proves evidence of genetic parentage. The current law allows a genetic person to be identified. However, staff find that at times there's already another party listed on the record. A statute does not provide DRVS the authority to remove the existing name. The amended record would contain a note that the record has been changed to show genetic parent and does not affect the right of inheritance or descent on the subject of the birth certificate. LD 24 language provides the allowance to replace a name when another party is already listed on the record. Over the past year, several municipalities closed to the public due to the COVID-19 pandemic. Parties intending to marry could not easily get their marriage license issued in person and therefore were unable to sign at the time of issuance. An amendment to the current language would allow the license to be signed when the marriage is solemnized. The person solemnizing the marriage is responsible for ensuring that all parties, including the witnesses, sign the license. Public Law 2019, Chapters 82 and 340, affected Title 19A, Section 651. The language in these laws created a conflict. One of the laws allowed intentions to be filed with either municipality or the state registrar with proper identification of the parties. The other law addressed whether either party intended to change their name after marriage. Language from both of these laws were incorporated as subsection 2. LD 24 would correct the conflict by combining the language into one subsection. The department introduced and supports this bill to provide consistency, clarity, alignment, and alignment with other vital records registrations and issuance processes. Thank you for the opportunity to provide testimony and information regarding LD 24. Maine CDC is available to provide additional details to the committee's consideration and to participate in the work session. Can I answer the question about the bank getting the electronic record? If I might. That
Please go ahead.
No, they cannot. The electronic system is available. That record is available to funeral directors, medical examiners, the municipalities, and the towns. And based on, in order to protect the person's record, confidentiality, the system is set up as a role based system where you, depending on what your role is what you can actually see and do with a record. So in order for anybody to get that record, they would have to get a paper record and take it to the bank.
Representative Craven, follow up? All set. Okay. Thank you, Ms. Hagan, for that answer. Are there any other questions for the committee? I don't see any, so thank you for being here.
Thank you.
As far as we know, there's nobody else to testify that I know of for this. Nobody's been contacting you to be added, have they, Carrie? Okay, then we're all set. So that'll conclude the public hearing portion on LD 24. And now we'll go to the hearing on LD 47. I don't see this. Go ahead, Ms. Withy.
Senator Claxton, can I have a few moments to notify the sponsor of the bill?
That will be fine. 5
Thank you.
minutes, do it?
Mhm.
We'll be back in 5 minutes while we wait for the sponsor to come in. Thank you. So it being closer to 6 minutes, we can resume our deliberations. We've been joined by Representative Brennan, who's going to be presenting us as the sponsor of LD 47. Welcome, Representative Brennan.
Well, thank you, Senator Claxton and Representative Meyer and members of the Health and Human Services Committee. I just zoomed over from the Education Committee to this committee, so I'm pleased to be with you this afternoon and glad that the technology ended up working. And I'm sure I'm not the first person that's come to the committee since you've been meeting that's been a former member of the committee and has extended my, saying apologies for not having a gift to bring to the committee and promised to provide something when in fact we meet in person at some time in the extended future. And I know over in the Education Committee, we have a long list already of people that owe us gifts, and we're keeping a meticulous list of those people who come before the committee, and I'm sure it'll be the same for you. So nonetheless, thank you very much for hearing LD 47. Let me just provide a brief history. This bill was first introduced in 2019. It was passed both the House and the Senate, and then it got swept up into the Appropriations Committee and died on the table along with hundreds of other bills that had been acted upon by the legislature back in 2019 and 2020. At that time, I serve on the board of directors of the Free Health Clinic in Portland. And I thought it was appropriate that the state provide some financial contribution to support free clinics across the state of Maine. Based on what I've looked at through the Maine Medical Association, there are at least 9 free clinics across the state of Maine. This bill asks for $250,000, which is a very modest amount of money to support the work of those clinics during these difficult times. We've had discussions for years and years about achieving universal health care in the state of Maine. We've looked at national level and we've also looked in the state. The fact of the matter is we're still almost 100,000 to 130,000 people short of having universal care in the state of Maine, and free clinics are oftentimes, unfortunately, the only health care that people receive in the state of Maine. I can speak best about what's happening in Portland. We have a free clinic that provides services, and I have to stress the fact that they provide primary care for somewhere between 500 and 600 people a year for a cost of roughly between $125,000 and $150,000. There will not be a bill that comes before this committee or before the legislature in the next 2 years that will leverage that kind of health care for that small amount of money. As you know, and I'm sure you've heard from numerous other people, because of the pandemic, the number of people that have lost health insurance has increased in the state of Maine. So what we've seen in the Portland clinic is more people that rely on the clinic because of the fact that they have lost their health insurance and don't qualify for other types of insurance in the state of Maine. So this bill is a very modest proposal in terms of the amount of money involved, $250,000 per year for the next 2 years that would provide support, would go to the Department of Health and Human Services to contract, establish an RFP process and contract with clinics across the state of Maine. Just for example, again, in Portland, I'm not saying, I'm just picking a number roughly, but if we were to receive 50,000 of that $250,000, we could increase at least by 100 persons the number of people that we provide services to. So again, when we look across the state and we look at the gaps that we have in the healthcare system, free clinics play an incredibly important role in the community in filling in those gaps. And this bill is an opportunity for the state to step forward and provide some financial support. And over the past year, I've approached the administration and the department at least 3 different times requesting CARES Act money and other resources within the Department of Human Services to try to fund these clinics and fund the bill. None of those have been successful. So that's why I'm back here today asking for your support. And I hope that you'll support the bill so that we can move it to the appropriations table and continue to have a discussion about how we can fund these important services on a very, very tight and limited budget. So thank you very much. And I'd be more than happy to answer any questions that you might have.
Thank you, Representative Brennan. And do I see anybody else? Yes, Representative Griffin has a question.
Thank you very much. Could you remind me where the other 9 free clinics are?
Off the top of my head, no. But I can tell you there's the ones that are most robust, meaning that they meet more than 1 day a week and have services more than 1 day a week, would be Portland, Oasis in Brunswick, Hope House in Lewiston, and I know there's a health clinic in Knox County, and there's one in Ellsworth, and there's a total of 9. And I think I've given you 6 at this point. But if you go to the Maine Medical Association webpage, they will list all 9. Or if you just Google free clinics in the state of Maine, they will then list all 9 of the clinics. I'm sorry, I didn't memorize them off the top of my head. But next time when I come to work session, I'll have them.
Thank you.
Representative Craven, you had a question?
Thank you, Mr. Chair. Yes, I do. Thank you, Representative Brennan. I remember this bill from last time. So with main care expansion, I would be guessing that a lot of people are covered. So I was wondering, who are the population that comes? And some people, I was talking to a person the other day who has Obamacare, and the deductible is so high that his kid had a rash on his arm. Do you know what I mean? So he had to go to the doctor to see what that was. And it was $250 up front, Right. And these are people who aren't well off by any chance, but they don't qualify for main care. I just wondered whether families like that who has large deductibles but still have insurance would be able to take advantage of the free clinic.
Yeah, I'm hoping that Caroline Tetchy will be testifying after me, and she's the president of the board of the clinic, and she would be able to give you a more precise answer than I am. But generally speaking, what you said, Representative Craven, is true. These are people that are over income and don't qualify for main care, but they are not offered insurance through their employment. And then signing up for the ACA for a bronze plan, they have a $5,000 deductible. So they truly fall in the cracks of main care, private sector insurance, and the ACA. And like I said, in the last year, we've served somewhere between 400 and 500 people just in Greater Portland through the free clinic. So if you multiplied that service across the state, the 9 clinics, you're clearly talking several thousand people in the state that either have an insurance plan that has significant co-payments or deductibles, or you have people that don't qualify for main care. And that's what I said, if we had a universal plan or some way of covering everybody in the state, maybe the free clinics, the role that they would play would not be as essential as at this point. But unfortunately, because of the pandemic, we've even seen more people lose what minimum health insurance they may have had through their employment. And I might add, unlike several other free clinics across the state, there are federally qualified agencies that people are eligible for. But in Portland, we provide specialty services as well. So if somebody needs to see a specialist, we do have an array of specialists who volunteer their time to provide services. And those are things that can't be accessed necessarily through the federally qualified clinics.
Representative Connor has a question.
Yes, thank you, Mr. Chair, and thank you, Representative, for coming. My question is, of the 9, so 250,000 in totality, Is there any mechanism of deciding how much each clinic gets? My rough estimate is $27,777 per clinic if we divide it by 9. Who decides how much each clinic gets of that money if this bill is passed?
Well, thank you for that question. And this is a very typical process. The money would be allocated to the Department of Health and Human Services. They would develop the metrics and establish an RFP process and make the money available to those clinics and have the clinics apply and make a decision on how much they would receive and oversee that contract. So it's a very straightforward process that the department does all the time, where they develop an RFP proposal, they develop the requirements, and then they allow the selected agencies to apply. In this case, I can't be guaranteed that every clinic would apply or would even have the necessarily the capacity to apply. I know in Portland would be able to, I know Oasis would, and I think several of the other clinics as well.
So would it be fair
I was not looking at this as 9 into 250, 27,000 for each one. I would allow the department to develop the metrics and then award the money based on need and the amount of service that they would provide.
Okay, so it would be a fair assessment that one clinic could get all of it, or 2 clinics could get all of it?
I would think that would be a mistake if the Department of Health and Human Services were to do that. The intent of this is to try to support that infrastructure across the state. And I think that they may make a decision that one clinic might get 15,000, another one might get 45,000 based on capacity and the number of people that they would serve and the leverage they would get as a result of that. I would be disappointed if the department awarded $250,000 to only 1 or 2 clinics.
I would be very curious to see what the criteria and the of the RFP would be for each, for those clinics. That would be my main concern, is to see what that is.
Which should be available to the committee as the department develops the RFP process going forward. So thank you for the question.
Thank you. That's all I have, Mr. Chairman.
Thank you. Anybody else with questions for Representative Brennan? There don't look to be any, so thank you for joining us from your other committee.
Well, thank you very much. And I assume that everybody's living in Zoom world as well as we are in the Education Committee. So I appreciate all the work that you're doing, and it's great that we're able to move forward, although in a limited way. So thank you very much.
So we've been joined by Anita Ruff, and I think there's a total of 3 or 4 people who'd like to testify. So we'll start with Anita, and if you want to unmute yourself, and you can start your testimony when you're ready.
Great, thank you so much. I got to put on my reading glasses. Sorry, age. Dear Senator Claxton, Representative Meyer, and members of the Joint Standing Committee on Health and Human Services, I'm Anita Ruff, and I'm the Executive Director of the Oasis Free Clinics in Brunswick, and I'm writing in support of LD 47. The mission of the Oasis Free Clinics is to strengthen our community by providing no-cost medical, dental, and prescription assistance services to our uninsured neighbors in need. Oasis serves adults who live in Freeport, Durham, Harpswell, Brunswick, and all of Saginaw County. And those are folks who are at or below 200% of the federal poverty level. Currently, we provide our free services to over 450 of our neighbors. Almost all of our patients work, many of them multiple jobs, and they either were not offered or cannot afford health insurance. Our medical clinic provides primary care services, including acute care, chronic disease management, women's health, and preventive services. Our community prescription assistance program connects those with low incomes to free medications through pharmaceutical free care programs, helping hundreds of people each year get life-saving drugs. Our dental clinic offers x-rays, fillings, extractions, dental hygiene, and oral cancer screenings. And finally, we help our patients apply for main care through our navigation program. On average, we leverage our budget of $370,000 into almost $2 million in free services for our community annually. Oasis was created over 25 years ago because there was a gap in the healthcare system. There was no place for those experiencing homelessness to receive free healthcare with dignity and respect. Unfortunately, there continues to be gaps in our healthcare system for many people, especially those who experience poverty, struggle with mental health and substance use issues, have limited literacy skills, and who bring complex lives into the exam room. This is why OASIS and the other free clinics in Maine are important. We serve those who need something different than the traditional healthcare system have available to them, and who are facing challenges that require more time than the traditional 15-minute visit. While Maine Care expansion has had a positive impact on many OASIS patients, it doesn't eliminate the need for OASIS nor the other free clinics in Maine. There is and will continue to be people who fall through those cracks and need the safety net of the free clinics. OASIS has never received state nor federal funding. For over 25 years, we've been supported by individuals, religious organizations, businesses, the United Way, and private foundations. I ask that you join them by voting yes to support LD 47 so that the free clinics help more people in our communities. I will clarify that there are 6 free clinics in operation right now, so not 9. There were 9 at one point, but we've shrunk in size. And I thank you for your consideration, and I'm happy to answer any questions you might have. Thank you.
Thank you, Ms. Ruff. Are there any questions of the committee? I don't see any. Oh, there's one. Yes, Senator Moore.
I'm just curious, when you're saying now that there's only 6, they're still showing 9 on the website. Which ones have closed, Anita?
Yeah, so right now, the ones that are currently operating are Portland, OASIS in Brunswick, the Knox Clinic, the Peninsula Clinic in Blue Hill, the Ellsworth Clinic, and Trinity Jubilee in Lewiston.
Okay, thank you.
Any other questions for Ms. Ruff? Okay, so that brings us, thank you for being here. That brings us to Carol and Teji. Would you like to unmute and join us? You're still muted, Ms. Teskey. There we go.
I was cool with all that. Good afternoon, Senator Claxton, Representative Mayor, and members of the committee. I'm Caroline Teschka, and I'm president of the board of the Friends of the Portland Community Free Clinic. And I'm here today in support of LD 47. The Portland Community Free Clinic, and the acronym is PCFC, which I may use from time to time, has served as a vital component of the healthcare safety net in Southern Maine for 28 years now. The Friends of the Portland Community Free Clinic was established in 2013 and is responsible for funding the work of the clinic. We've been successful in this endeavor, but the work to raise money is constant and ongoing and has been seriously impacted by the COVID-19 pandemic. The pandemic has increased the need for the services of the clinic, while at the same time straining the resources of the organization. The free clinic has seen recently and expects a continued upsurge in demand as thousands of people continue to lose their jobs, income, and in many cases, their health insurance due to the ongoing pandemic. As hospital resources are strained by treating those most acutely ill with COVID-19, the need for primary care, mental health counseling, and outpatient care is greater than ever. The Portland Community Free Clinic cares for adults as OASIS with incomes at or below 250% of the federal poverty level who lack health insurance. Typically, patients are low-income workers who are not offered health benefits through their employers. This number has increased over the last year, as I'm sure you know, and current estimates are that between 72,000 and maybe up to 130,000 Mainers have lost their employer health benefits or can no longer afford coverage in the ongoing pandemic. Approximately half of these individuals, we think, may be eligible for Maine Care, but thousands will join the ranks of the uninsured. And the Portland Community Free Clinic is a vital resource for these displaced and uninsured workers. We operate on a modest budget of approximately $10,000 to $12,000 per month, for which we leverage about $2.4 million in medical service. The Friends is an entirely volunteer board, a lot of older women like me, and many of whom have been volunteers in the clinic throughout the 28 years of its operation. All the medical providers are also volunteers. And we raise money by applying for competitive grants, holding community events, including an annual golf tournament, which obviously didn't happen this year, and conducting a year-end appeal. In 2020, competition for funding has increased, and we're also finding that there is some donor fatigue as more needs emerge, understandably. Since March the 30th, we have seen an increase in uninsured patients. Some are former patients who've returned to the clinic because they lost their jobs and insurance. Others are new patients with job and insurance losses. And we're also seeing patients now who've come to us from another free clinic that recently closed, and that was Levitt's Mill in Buxton. The 108 volunteer physicians, nurses, nurse practitioners, social workers, counselors, and receptionists who share their time and expertise allow us to offer very high quality healthcare. Increased funding would allow us to expand our work, serving uninsured adults who live in southern Maine. Specifically, we think we would be able to support expanded primary care access for an additional 100 patients, if not more. As part of, so we'd like to increase our patient panel from roughly 500 to 600 or greater. As part of the response to the pandemic, the clinic is now offering telehealth, and we'd like to grow this capacity by at least 100%. This would provide a greater safety for both patients and our providers. In particular, there's an urgent need for mental health services at this time, as patients, their immediate family members suffer job loss, income loss, illness, and in some cases, death. Telemedicine is of great relevance in the provision of effective mental health services. Finally, financial support to continue this work is essential. The Friends of the Portland Community Free Clinic is dedicated to ensuring this high quality healthcare is provided by the clinic. Funding will help ensure that we continue to meet the rise in critical need brought on by the COVID-19 pandemic and continue to provide its vital safety net role in the medical landscape. Thank you very much for your consideration and support of LD 47. I'd be delighted to answer questions.
Thank you for your testimony. Yes, Representative Zager.
Thank you, Mr. Chair. Ms. Teschke, thank you so much for your volunteer work and for coming here today to help us understand this and what the clinic is doing. My question is regarding equity. It can be many different dimensions or facets of that. And I know that your clinic does a lot to help improve healthcare equity. But can you provide a little color to that, with numbers or story, or how that how we're not only getting people care, but making sure that it is done in an equitable fashion?
Right. Well, we have 4 essential criteria for coming to the clinic. First of all, you have to be over 18 because we're not equipped to do pediatric care. Secondly, you have to have no health insurance at all, and you have to be at or below 250% of federal poverty. We also have criteria that you should be in Cumberland or York County, but we are pretty relaxed about that. We don't want to turn people away. In particular, with our limited budget, one of the things we can't provide because it's very expensive are interpreter services. However, we do recruit providers with specific language capabilities. So we are able to see Spanish-speaking patients because we have Spanish-speaking doctors, nurses, and nurse practitioners who are comfortable to do that. As far as seeing a wider range of BIPOC peoples, we feel that they're better served at the Federally Qualified Health Centre, where they have a very robust interpreter service. However, if language was not an issue, we're open to, to taking people who fit our criteria, and are happy to do so. I think that we're open to as much diversity as we're asked to accommodate, and racial justice and equity are a very important tenet and central principle to us. Does that address what you were looking for?
It does. Thank you very much. I appreciate it.
Representative Lemlin.
Thank you, Senator. I have two quick questions. One, the person before you said 200% below the poverty level, and you are saying 250% below the poverty. Which number is actually accurate?
Well, 250% is accurate for our clinic. We're not, we all have respect and some communication with each other in the free clinic community, but our criteria are not necessarily uniform. For example, one of the free clinics is predominantly there for women's healthcare. We see both genders, and I think OASIS does too. And I may be wrong, but I thought that Anita said that they had a 250% limit as well. I don't know if she's still here to confirm that. But ours is 250%, which is roughly for a single person, as I'm sure you know, between $28,000 and $29,000 a year.
Okay, thank you. And the second question is, approximately, what's the average monthly cost of running your clinic?
It is between $10,000 and $12,000. So as Representative Brennan pointed out, that gives us an annual budget of anywhere between 120 and 150 roughly thousand. And the difference in a year would depend on things like medical supplies or supplementary costs that we may need. All our medical services are provided free and by volunteers. So what the money goes to is ensuring that when a doctor comes in to do primary care, say for 3 hours on a Thursday night, that person can operate at the top of their license. They come in, they just see patients. All the scheduling of the clinic, the arranging for testing, any of the administration that needs to go on a day-to-day basis, because we are open 5 days a week and 4 evenings a week as well, in addition to the days, is done by support staff. And most of our money that we raise goes to paying those support staff.
Okay, thank you very much.
Representative Meyer.
Thank you, Mr. Chair. Thank you, Ms. Teskey, for being here today and for the work you're doing at these important clinics that serve such a critical role in the communities that they serve. So my question is, do you have staff that is well-versed in and able to connect folks with some of the other safety net programs that are available through the state?
I'm really glad you asked that question, because we're not in competition with anybody. We see ourselves as part of the landscape. If somebody contacts us, and that's why we have staff who are not volunteers, and we're not suitable for them, we make every effort to connect them with an organization such as the Federally Qualified Health Centre in Portland that may be able to serve them. We also try and link them to possible avenues for health insurance. For example, if by talking to them, we find out that they could be main care eligible, then we encourage them to do that and to seek their primary care, not through us, because we're there strictly for people who are uninsured. So we do, that's very much part of our mission. We want everybody, I mean, to be honest, a perfect world, we wouldn't be needed. We would do ourselves out of business, but we're not there yet. So we see ourselves, as I say, as part of the landscape, not trying to compete with other organizations, or the only aim is to get people where they need to be to get the care they need. Does that answer that? No, thank you.
Thank you for your testimony. I don't see any other questions of the committee, so I'm going to check in with our clerk to make sure there's nobody else that we know of who wants to testify.
Yes, Senator Claxton. Megan Hanan is with us.
I'm sorry. Yes.
And
Yes.
there are a few others after.
Okay, good. All right. So welcome, Ms. Ann.
Hello again. Good afternoon.
Hello.
Senator Claxton, Representative Meyer, ladies and gentlemen of the Joint Committee on Health and Human Services. I'm Megan Hannon, Executive Director of Maine Community Action Partnership, and we also support LD 47. The population of the 10 community action agencies across the state serves is primarily low-income Mainers. Many are MaineCare members. Some have health plans through the Affordable Care Act or their jobs, but too many Mainers still fall through the cracks. As you likely know, and we had just confirmed, there are not many standalone free clinics left in Maine. Oasis Free Clinic that you've heard from in Brunswick is the one near me. They serve about 450 patients, including medical, dental, and a small number of social worker case management patients. Anita did just text me to let you know that indeed they do up to 200% of poverty level. And as Dr. Teschka said, there's a difference depending on what they have. The modest funding that this does, only $250,000, would allow them and the Portland Clinic to expand their capacity in Brunswick at Oasis, especially dental and mental health capacity. And it will expand the capacity of all the clinics in a way that benefits both the patients and the community in very cost-effective ways. Dr. Teschka did not mention this, but I was involved and remember well when a few years ago, the city of Portland decided to close its free clinic. But community outcry, led by Dr. Teschka, led a group of providers and community members to keep it open. Even in a city with 2 major hospital systems, a federally qualified health center, and many primary care providers, this service is needed. Federally qualified health centers are an excellent alternative and are throughout the state, but they are reimbursed for services in a manner that include uninsured, so the business model works differently. Hospital systems also offer limited free care as a required community service, but as I said, there are still people who fall through the cracks. We do support all of these models. Moreover, we support the more equitable healthcare system that ensures all Mainers have access to quality, affordable healthcare in a meaningful, geographically, and as Representative Zagler referred to, culturally appropriate way. Until such time, the few remaining free health clinics need our support so they can support Maine families. I'm happy to answer any questions I can. Now we're in the work session.
Thank you, Ms. Hannon. Has anybody else got any questions to be passed along? I don't see any. So we also have been joined by, looks like Dan Moran and then Meredith Betley. Mr. Moran, please join us.
Good afternoon, the Honorable Ned Claxton, Honorable Michelle Meyer, members of the Joint Standing Committee on Health and Human Services. The Maine Medical Association appears in support of LD 47, an act to fund the state's free health clinics. The MMA is the state's largest professional physician organization representing more than 4,300 physicians throughout the state. These range from employed physicians at hospitals and large health systems to independent community physicians ranging from Intermed, one of the largest in the state, and solo practitioners and all by themselves, just like the old days in Steep Falls and Millbridge and various areas throughout the state. Born and raised in Lewiston, live in Gorham, been working for the Medical Association since last January. And we have interacted recently with free clinics, specifically the Portland Free Clinic. Equitable access and distribution of pandemic resources has been a core effort of us in the leadership over the last year. And it hasn't been just on behalf of physicians. We worked with the Portland Free Health Clinic in order to try and find all their volunteers and staff vaccines with the limited supply coming out. I pretty much think they've been successful up until now. And we've also worked with other medical providers. As you heard earlier from Representative Brennan and Anita, the Maine Medical Association has made physician voluntary work both in Maine and overseas a major focus. Our website has a list of free medical clinics, and as the communications director, I am the one responsible for updating the webpage, and it looks like I need to reach out to Anita, who I used to work with in a previous job, to update that list, and we'll be glad to do that as quickly as possible. We strongly support LD 47 to ensure the needed funding for these critical state safety net programs. We've all heard about the healthcare disparities that exist within our healthcare system. This is one way to address that. They remain critical to the uninsured and the underrepresented in Maine. And as a side note to that, we formed a committee on race, ethnicity, and healthcare disparities in 2020. And one of those goals is to eliminate racial, socioeconomic, ethnic, demographic, healthcare disparities. And as a result of the initial work of that committee and our board of directors, we considered bills like this to be core foundational issues to support for our organization to ensure healthcare access to all, including those who don't have access to it because of affordability. So thank you for accepting our comments. We'll be available to work on any potential amendments before the work session, and we will be in virtual attendance when that work session comes up. I'd be happy to take any questions.
Thank you, Mr. Moore. Does anybody have any questions? Yes, Representative Zager.
Well, thank you, Mr. Moore, and I so appreciate you coming by. I actually wanted to just state for the record my apology to Dr. Teschke. I want to honor our standard here to acknowledge people by their titles.
Any questions that anybody would like to pose? Then we'll move to Meredith Batley and hear from you when you unmute.
Good afternoon, Senator Claxton, Representative Mayer, and members of the Health and Human Services Committee. My name is Meredith Batley, and for 12 years now, I've been the executive director for the Knox Clinic in Rockland. And I'm speaking, of course, in support for LD 47. In 1 year, our volunteers and staff provided over 3,000 low-cost or free medical, dental, and mental health care appointments to our neighbors without insurance or who are underinsured. We also saved our community over $1,300,000 in prescription costs in 1 year. And these numbers mean a great deal. However, it's the individual patients and their stories that keep our team of physicians, nurses, dentists, clinicians, and receptionists volunteering for 10, 15, 20 plus years now. And I wanted to share, there's one woman who's been on my mind a lot lately. We recently connected with a young waitress who moved from Northern Maine to Rockland for a new job. And she's already been battling with lifelong depression, but the added financial stress and isolation and anxiety from the pandemic drove her to thoughts of suicide. And not having insurance only increased her fear of seeking help, and she spiraled further into despair. And without help, she could have lost her job, her housing, or even her life. And fortunately, she connected with our team at the Knox Clinic here. And for the past 6 weeks, we've been providing her with free counseling, with free medical care, and the support that she needs right now to recover. And I keep thinking about what would have happened had we not been here for her. And so she really has been an inspiration for me to do more. And that's why I'm here today. Knox County is the only county in Maine without a federally qualified health center on the mainland. Ours is out on Vinyl Haven, which is about an hour ferry ride away. And like the other free clinics, we do not currently have federal or state or, of course, insurance funding. And for over 21 years now, the Knox Clinic has been a safety net.
30 seconds, Ms. Batley.
Thank you, for those who have nowhere else to go. So I please encourage you to see our written testimony, and our volunteers and part-time staff would be so grateful to receive your support so we can do what we do best, which is taking care of our neighbors in need. Thank you.
Thank you for that testimony. Is there any questions for Ms. Batley? I don't see any, so I thank you for being here. And I will check in again with our clerk to see if there's anybody else out there who'd like to testify related to LD 47.
Those are all of the signups I have, Senator Claxton.
Okay. So at this point, then, we'll conclude this public hearing portion of our afternoon on LD 47. And we'll collect questions that the committee might have for the analysts for LD 47 and 24, if there were any left over. Anything that we would like to direct to Erin to have available for us when we get to a work session. She's already forwarded the list of clinics. Anything else? Looks like there isn't stuff to be done in anticipation of the work session. So that'll conclude this portion of the afternoon. The way things are set up, our guests will be here in about a half an hour officially. Is there any harm for starting earlier, Erin?
I'm not sure. We're waiting for Bethany Mogan from the Silk to present as one of the statutory bodies.
Okay.
I'll have to ask Anna if we can start early. I'm not sure about that.
Okay. So should we just adjourn until 2:30 then? Anybody got any recommendation? A motion?
So moved.
To adjourn.
Okay, so we will adjourn until 2:30. Hear from a statutory body if they are around, and then go to hearing from interested parties. Okay, we'll see you at 2:30. Okay, welcome back to the continuation of the Committee on Health and Human Services hearing this afternoon. We'll be hearing from the folks at the Statewide Independent Living Council. And I understand that either Beth Morgan or Cheryl Peabody are here, or both. And we can start with them before we proceed to hearing from some interested parties.
Great, thank you. My name is Bethany Mogan. Cheryl Peabody's not with us today, but I would like to say good afternoon to Senator Claxton, Representative Meyer, and members of the committee. Again, my name is Bethany Mogan, and I'd like to thank you for the opportunity to be with you today to share some information about the Maine Statewide Independent Living Organization. Our organization is referred to as Maine Silk, S-I-L-C, so not the typical spelling. So Maine Silk is a nonprofit organization that is not contained within any agency within the state. Maine Silk is dedicated to ensuring individuals with disabilities have control over their lives and environments with equal access to options, opportunities, and choices as do all citizens. Maine Silk stems from the Rehabilitation Act of 1973. And as a result of the act, the inception of Centers for Independent Living was formed, as well as vocational rehabilitation and the statewide independent living councils. In fact, in Maine, New Hampshire and Vermont are the only 3 states that have one CIL, which is a Center for Independent Living. Here in Maine, that CIL is called Alpha One, and every state has only one statewide independent living center. So to give you a little perspective, many states will have, they could have 40 independent living centers or centers for independent living, and they have to choose a representative to sit on the statewide independent living council to represent all of their centers for independent living. Sorry, my voice is, had some problems with my voice and losing it lately, so I apologize. So Maine's goal is to reach individuals with disabilities, find out what their needs are, what their direct needs are, what they would like to see going forward, what would help them. And so our role is help influence public policy by supporting opportunities to live independently and within their chosen community. I would like to share with you why and it's a movement. It's not an act or a bill. So independent living is not residential, but it's more a movement. So I'd like to share with you why independent living movement is so important to me. Keep in mind again that this is a movement. So I am a Maine native. I have 2 older sisters. Neither have a disability. My parents had the same expectations of me as they did my sisters. I was born with a form of muscular dystrophy called spinal muscular atrophy, and have never been able to walk independently. So at the age of 10, I started using a power wheelchair for mobility full time. I attended public schools. So giving away my age, I'm 51, but so back then I was one of the first children to be mainstreamed into the school system that had a disability. So in high school, I wanted to be just like my sisters. So I asked my mother if I could work. I found a data entry job where I could work part-time after school. My senior year, in addition to my data entry job, I also took on another job after school. Well, it was like half after school. So I would attend school in the morning until noontime. I would leave school, go to work until 5. And then I had the data entry job on the weekends. So I'm a pretty driven person. I also had decided early on that I wanted to go to college. I applied to the University of Maine at Farmington. And during my orientation, I met with my professors, administrators, and peers. I would be the first person to be living on campus with a disability, the dorms, and attend classes. And they had never had that before, so they didn't know what to expect. The administrators took my mother and I aside and said, you know, the winters are really harsh in Farmington, so you'll only be able to probably attend the fall semesters. So I looked at my mother after they left and I said, you mean I'm going to have to go to school for 8 years for a 4-year degree? I don't think so. So we pushed them. We pushed them to think outside the box as to what I would need to help me get through my 4-year goal. So as you can imagine, it was new and different. Back then we didn't have cell phones. They had the college lines in the hallway, and you know, somebody would ring and they'd yell the name down the hallway. But I had a phone in my own room. That was one of the measures that we did for safety. And then here's a really comical visual for you. On one occasion, I actually had to follow a snowblower to class. So, because that was the only way I was going to make it to class. So that's not embarrassing at all. But I did obtain my bachelor's degree in 4 years, I'm happy to say. It was challenging, to say the least, in finding jobs as well. So it goes against the grain, but I would always tell the interviewer to ask me any questions that they wanted to, even if it was about my disability. The reason for that is I felt, as a person with a disability, I would rather have the person ask me if I'm able to perform a task or what a solution might be, as an alternate or alternative, rather than them think of whatever in their head. So just assuming I can do it. So for example, photocopying, because one of my jobs was an administrative assistant. So I couldn't physically do the photocopier, but what I did is I would have a coworker do the photocopying, and I would take some tasks from her list. Like it might be setting up travel for a manager or setting up meetings and things of that nature. So my kind of look on life has been, if there's a problem, there's a solution. It's just a matter of finding it. So in August of 2018, I was offered the position of executive director for the Maine statewide Independent Living Council. It has been an honor and a privilege, and I hope that I'm able to represent the disability community in a positive, motivating way. And also noting that change can happen. It takes time, it takes effort and passion to get there. I would like to congratulate all of you on your appointments and reappointments to serve all areas across the state. I believe you wouldn't be here unless you had that same passion for making a difference and a change that would be better for everybody. And as you know, you have a big task ahead of you. It's not going to be easy, but with hard work, waiting to decide the outcome before, waiting until you have all the information, basically, before you make an informed decision. And then the accomplishment will seem that much better. So one last thought, as I was thinking about 2020, as we were all struck by COVID and various events of last year, I was thinking life is not a contest. One person is not better than another. One disability is not better or worse than another. It's all relative. And you have to live your own life and not somebody else's. So people with disabilities should be treated with dignity and respect, as all people should. So I thank you very much for your time.
And thank you for your testimony and your perspective. Glad you could be here. I think there's a question from Representative Craven.
Thank you, Mr. Chair. And thank you very much for sharing your story, Bethany, and for all of your courage and determination. You're an inspiration, so thank you for being here.
Oh, thank you.
Does anybody else have a question or comment for Ms. Morgan? I don't see any, so thank you again for being here. And
thank you. Thank you.
Keep up the good and hard work.
Thank you. You as well. I know, as I said, I know it's going to be a challenge. You have a lot of tasks ahead of you, but you'll succeed. I have faith.
The next challenge we're facing is that we have a bunch of interested parties who will be joining us. And we have a list that at this point numbers 26, as I understand it. So at this point, unless Aaron or Anna wants to say something else, we can start to admit people in order off of that list. And I would ask that everybody try and limit their comments to 3 minutes so that everybody gets a fair chance to be heard. Thank you. So first, I'm looking for Courtney Allen. If you want to unmute and join us, we'd be glad to hear from you.
Hello, my name is Courtney. Good afternoon, Senator Claxton, Representative Meyer, and honorable members of the Health and Human Services Committee. Again, my name is Courtney Allen. I come today before you as the Policy Director for the Maine Recovery Advocacy Project. MERAP is a statewide coalition of grassroots organizers in the recovery community coming together to redefine and reimagine justice, access, connection, and recovery. Our primary goal is to ensure that people in recovery, family members, and any supporters of the recovery process have a voice in their local and state government. We do this through a listening first model. What that looks like in practice is that we go out into our communities and listen to people directly and indirectly impacted by the recovery process in Maine. We then take what we learn from them and bring that to you all. I do not represent any particular substance use disorder treatment or recovery program. Neither do any of the organizers or advocates that will come before you this session, even though many of them do work in those programs. I particularly work for people directly on the ground in Maine who are in or seeking recovery, who have lost their lives to overdose last year and all the years before, and the folks who do not normally engage in public discourse on this topic. While I will be before your committee this session to offer testimony on any subject that's identified as important to my community, we do have one bill in particular that is our priority. An act to expand recovery organizations throughout Maine proposed by Senator Maximum. This bill would fund $1 million grant to the Department of Health and Human Services to open recovery community organizations in the 7 Maine counties that do not currently have one: Kennebec, York, Waldo, Hancock, Franklin, Somerset, and Piscataquis. An RCO is an independent nonprofit center staffed and governed by people in recovery with and for people in recovery. RCOs provide a safe space for people and support multiple pathways and provide 3 key things: peer-based recovery support services like recovery coaching, telephone support, and meetings or activities, as well as public education and policy advocacy. RCOs are not treatment centers, housing providers, or needle exchanges. The centers are able to connect people with those resources if they need or want. The bottom line is that RCOs act as a connection center for people in recovery and their family members, to recovery coaches, self-help groups, things like AA, NA, yoga, education, employment, and whatever else they may need. In 2016, your committee approved a pilot project to fund 9 new RCOs in rural communities and the Maine Recovery Hub, overseen by the Portland Recovery Community Center. Since that original funding, 4 centers have received small grants to open from DHS as well. This bill seeks to close that gap to include all of the counties that do not currently have a center. For today, I will leave us with that. We look forward to working with all of you this session, and feel free to reach out to me if you have any questions about recovery, treatment, overdose, the war on drugs, et cetera, et cetera. I am here to help, and if I don't know the answer, I can find somebody who does. So thank you for your time. I'm happy to answer any questions, or that's not how we're doing it today.
Well, thank you, Ms. Allen. I don't see any pressing questions, but we could do it that way if we wanted to, but thank you. Next we can hear from Bradley Sawyer.
Thank you, Senator Claxton, Representative Meyer, and members of the Joint Committee on Health and Human Services. I come to you again after testifying yesterday on a couple bills. My name is Brad Sawyer. I'm the Director of Government Affairs for the Maine Rural Water Association. A little bit about us. Maine Rural Water is a nonprofit trade association representing just under 300 water and wastewater systems across the state. Our membership spans from the smallest water districts with 10 to 20 connections, all the way up to some of the largest utilities with thousands of water and sewer connections. That being said, we assist all utilities in the industry, and last year visited 529 systems and spent just about 2,800 hours on site. We have a statewide policy committee that provides guidance to rural water staff on legislative and regulatory issues and concerns to the industry. It's important to note that the vast majority of these utilities in Maine are municipal or quasi-municipal entities and are responsible to their ratepayers and not the pursuit of profit. We call them ratepayers, you call them taxpayers, they are the same people. You will undoubtedly hear me say that more and more this year. We currently have a staff of 17 and provide training for, technical assistance to, and advocacy on their behalf. Our training slate is quite robust. In 2020, despite the pandemic, we held 90 training classes, accounting for over 2,400 training classes for operators, staff members, and members of the boards of utilities. And we have classes tailored to all of those groups and also classes tailored to extremely small utilities. We're also a leading partner in technical assistance. We assist utilities in real time as they deal with leak detection, pipe and valve repair, wastewater testing, regulatory compliance, financial services, and really all aspects of running a utility. This may sound mundane on the surface, but it is incredibly real, and failures can threaten the safety and quality of drinking water and pose hazards to the environment that we are all seeking to protect. Our membership takes their charge to do this incredibly seriously, and they're proud of the work that they do in these industries. We also help protect the sources of the water. We have a source water protection expert, and it's a fairly simple concept. It's easier to treat and provide water if you're starting with a clean product than starting with a dirty product. You'll undoubtedly see me more throughout the year, but I don't want to take up more time than I need to. I'm happy to answer any questions now or offline, and I certainly hope folks will engage me and our organization moving forward as you have questions about the industry. Thank you very much. Good luck, and I look forward to working with all of you.
Thank you, Mr. Sawyer. Next, we're going to hear from Rick Erb.
Good afternoon, Senator Claxton, Representative Meyer, members of the committee. My name is Rick Erb. I am the president and CEO of Maine Healthcare Association. We represent the nursing homes and assisted living facilities. I've been doing this for almost 20 years at this point, and it's a real pleasure to be with you today. I think everyone in Maine knows that we have a growing elder population in Maine. Certainly people who serve on HHS committee are aware of that. It's also a fact that since 1994, when some changes were made, there actually has been a reduction in the number of nursing homes and the number of nursing home beds. In that period, there also has been an increase in assisted living. And what we are finding is that people who live in assisted living in Maine would more likely be nursing home residents elsewhere. Maine also uses a higher level of Medicaid for its assisted living than just about any other state. Our assisted living facilities do have high residential needs. More than half have a dementia diagnosis. The average age is 83, and about 3/4 of them are paid for through the Maine Care program. Nursing homes are actually somewhat similar. 70% of them are paid for through Maine Care. They have higher staffing levels. They also have a high rate of dementia diagnosis. Both types of facilities are very full. We're temporarily at lower levels of occupancy, but normally most of them are around 90% occupied, about the highest in the country. We are certainly concerned about future needs, looking at the demographic shift that we are in the midst of. Population that we are serving is going to continue to grow, especially the oldest old, those are 85 and up. So these are priorities for us. I did provide you with a slideshow, which I think has been emailed to you. I hope you'll take a look at it. There is a final slide there that shows some comparison of national data on COVID-19, comparing Maine with other states. And as you look at it, you'll see that Maine's nursing facilities have a smaller number of COVID cases per 100 residents than the national average. We also have a smaller number of COVID deaths per 100 residents. On the other hand, though, there are some negatives there. Maine nursing homes report having smaller amounts of PPE on hand. I'm sure you're familiar with personal protective equipment. It also indicates that they are more likely to indicate that there is a staffing shortage. The staffing shortage is probably the biggest issue that we are facing, apart from the immediate emergency situation with COVID-19, but also related to it. It is a workforce issue. Maine is challenged by demographics and low unemployment rates. We also have higher staffing requirements than other states. So certainly the perception is that we need more people than others. I would just say that, looking at those charts and comparing us to the nation, I'm proud of the job that we have done managing COVID-19. We still have a long ways to go, but we've done an excellent job of doing the best we can to control it here. It's expensive. It's more restrictive than we would like long-term care to be, but we are keeping COVID out to the maximum extent possible. I can only say that COVID-19 has stretched already thin resources even further. More work is needed to be done, especially on staffing. We need to streamline the process for our caregivers to be licensed and certified. And I'm looking forward to seeing bills come before you that will address that. Thank you very much.
Thank you. We'll look forward to seeing you as those bills progress. Next, we're joined by Becca Matasovich. If you would care to unmute and join us, that'd be great.
Great, thank you. Hello, Senator Claxton and Representative Meyer and distinguished members of the HHS committee. My name is Becca Matasovich, and I'm the Executive Director of the Partnership for Children's Oral Health. The partnership is a statewide network of many organizations and key stakeholders committed to a common vision, which is to make Maine a state where all children can grow up free from preventable dental disease. We're funded by private philanthropic dollars, in large part by a generous multi-year commitment by the Sadie and Harry Davis Foundation to support our core operating costs. And we're able to leverage additional grants and private resources to help support the collaborative work of our partners in this network. We have a very small backbone organization. It's a nonprofit with just 2 staff, myself and Associate Director Kaylee Hess, but we convene and coordinate hundreds of partners in a very effective public-private partnership. These partners include dentists, hygienists, primary care providers, state agencies, community organizations, school nurses, CAP agencies, universities, and many others. There is a role for everyone in our work. We work on building the capacity of our network through strengthening the data that is available on oral health, policy analysis and advocacy, communications, and relationship building. And as a network, we're focused on 3 strategic priorities right now, which include integrating oral health into primary care, expanding prevention in school and community settings, and ensuring access, quality, and sustainability through the system that provides oral health care for all Maine people. There's a little more information in the handout that I provided. Basically, I just want to say that we're happy to serve as a resource in any way that would be helpful to you, whether that means sharing data that we've analyzed, to share insights from our various action teams and work groups, to help connect you to people with particular expertise or perspectives. I'm not a clinician myself. I come at this issue from a longstanding passion for children's well-being. I've been a teacher, a parent, a patient, and I worked for DHHS for 18 years. So I do understand this issue from many different angles, but I also can connect you to many people throughout the network who have many more angles than that. I'll be back before you on several different bills this session that have excellent potential to help us move toward a future where all Maine children can grow up free from preventable dental disease. So I look forward to seeing you again. Happy to answer any questions.
Thank you for that testimony. We look forward to seeing you.
All right, thank you.
Next, we'll hear from John Royce.
Okay. Thank you, Senator Claxton, Representative Meyer, and members of the Human Services Committee. My name is John Royce, and I'll be representing the Maine Chiropractic Association this session. I'm a resident of Augusta, and I certainly look forward to working with all of you in the coming months. I know there'll be several Maine care issues as well as other issues before the committee that the Maine Chiropractic Association will be interested in and supporting. Your committee is one of the hardest working committees in the process. Certainly, I've been involved for quite a few years, so I know that. So I'll try to keep my information as brief and to the point as possible, and I will certainly miss being there in person this year. Thank you. Happy to answer any questions.
Thank you, sir. And we'll look forward to asking questions as we get bills in front of us.
Thank you.
We're also joined by Jan Collins. Good afternoon.
Greetings, Senator Claxton, Representative Meyer, and members of the Health and Human Services Committee. My name is Jan Collins. I'm Assistant Director of Maine Prisoner Advocacy Coalition. I am the mother of someone who is incarcerated, and my father was also incarcerated. I think many of the things that MPAC is concerned with are near and dear to your hearts. Our mission is to support Maine's incarcerated citizens, their families and friends in their struggle with Maine's criminal justice system. Our purpose is to reduce Maine's use of incarceration by creating a criminal justice system that is ethical, humane, and restorative in nature. We are an independent nonprofit. We partner with a variety of different organizations who share our values, and as well as with the Department of Corrections, with whom we are in regular contact. Some of our priorities include substance use disorder and mental health. Maine's jails and prisons are filled with people who could be better served in a medical setting. It's less expensive to place a person with substance use disorder in a treatment bed than in a jail cell. Yet we continue to place them in jail. The High Consent Decree released hundreds of, if not thousands, of people suffering from mental health issues into their communities, unfortunately, without adequate support services. Coincidentally, since the High Decree, the prison population has risen proportionately. Prison exasperates and treat mental health issues. In addition, we are concerned about the juvenile correction system. The juvenile budget this year will be $12 million on community corrections and $18 million for Long Creek. Long Creek serves a population of less than 30 children. That breaks down to over $600,000 per child. We believe that that money would benefit those children and their communities much better if it was spent in support systems instead of locking these children up. In most states, juvenile detention is part of human services and not under the auspices of an adult corrections department. The burden of mass incarceration falls heavily on the children and families of inmates. You may be aware of the recent release from the Cutler Institute, a report called Breaking the Cycle, which outlines steps that can be taken to increase the likelihood of more positive outcomes for these children. This study builds on a still relevant 2016 report from the Annie E. Casey Foundation. Along with some other things, we are very interested in expanding reentry services, which are lacking in jails and prisons and lead to a high rate of recidivism and a cycle of despair. We need more recovery homes, and job training. On the other end of the life cycle, it is time for compassionate release for the dying. Jails are not prepared to be nursing homes, and yet that is what is happening. As our crime rates are declining and arrests are down, our prison population has continued to rise with the exception of this year of COVID. Longer sentences mean our prisons have a disproportionate number of the aged. It is time to release the elderly, infirm, and dying so they can be cared for in a licensed long-term care facility. And the last topic for today is the COVID-19. It's a ticking time bomb. It has completely shut down all educational services, with almost all educational services within prisons and all programs. People in the prisons are now pretty much in a system of solitary confinement. That's all to keep them safe, and yet we have refused to include them in our plans for COVID-19 vaccination. 95% of all inmates have a release date. They'll be returning to our communities. We must return them restored, rehabilitated, and whole. Thank you. I'm willing to answer any questions you might have. And thank you for inviting me.
Thank you for your testimony, Ms. Collins. I have a question from Representative Craven.
Thank you, Mr. Chair. Thank you for the presentation. I do have a question about the compassionate care for the dying. If somebody was released from the prison, would they qualify for main care to be cared for in a nursing home?
My understanding that main care covers hospitalization that's overnight, and it also covers nursing home care. Now, that was from testimony that was submitted to the Criminal Justice Committee 2 years ago. And it could be outdated, but that's my understanding at this point.
Okay, thank you very much. Next, we're joined by Betsy Sweet.
Hi, and thank you so much, Senator Claxton, Representative Myers, and members of the Human Services Committee. Let me just say, first of all, thank you so much. I know these are long days, and I have always had such respect for those of you who serve and step up to serve. And I know it's a hard job, and this year it's even a harder job. So I just want to say thank you. This is my 38th year working at the State House as an advocate for Maine people. And so I thought like I'd seen it all, but but I haven't. So I'm the owner and principal of Moose Ridge Associates, and we are a firm that represents all nonprofit social service and environmental organizations. And we have been working with the Health and Human Services Committee and Department for many, many, many years. You have heard many of our clients come before you, so I'm not going to talk about them except for the Behavioral Health and Community Collaborative. It is the thing that I work most on, which is nonprofit community mental health services. And we will be before you with many bills, but at a time in our society with COVID, when we see the issues of mental health, and just like Jan was just saying, and Rick before her, we have people placed in places where they don't belong, and almost always it's due to a lack of community-based services. For the last 2 decades, the amount of money that we spend on mental health ironically goes up, but the amount of money we're spending on community mental health, which is cheaper, closer, has best outcomes, is going down. So we're seeing more of that money spent in hospital emergency rooms and in prisons and even in our schools than we are in the services that could actually meet people where they are and help them where they are. The biggest challenge we face, much like Rick, Herb, and the elderly, is in staffing. We have a workforce shortage, and the pay that we can offer, we used to compete between like developmental disabilities and the elderly and other folks, childcare. But now we're not competing between each other. We are now competing with Walmart and McDonald's and those organizations that pay more than we are able to pay for jobs that people don't have to take home at night with them. So it is a huge challenge. And I know that you are being put in the position, and have been for years, of what I call the Sophie's choice of which population are you going to help out this year? Is it going to be the older Americans? Is it going to be DD? Is it going to be mental health? And that's not a fair position for you to be in. we are looking very much at trying to help figure out a way to raise this entire class of direct care workers, much as we did for teachers. That's a proposal that's still much in formation, but we will have many, many specific bills about particular services. We have huge wait lists for children services, for home and community treatment, and Representative Madigan has done such a wonderful job advocating for them. In our outpatient services, in one agency alone, we have a waiting list of over 500 people trying to see. So we do all these great things and say, get help, call 211, do this, and provide services, which is awesome during COVID. But then when they call, they can't access services for a month or 2 months or 3 months. And you know what it's like when you need help. Waiting 2 or 3 months sometimes is not an option. So, and then they're driven into more expensive and less effective services. I represent the Behavioral Health Community Collaborative is 7 organizations, and you've got a list of them. I'll give you another one later. But together we serve 82% of the people who are receiving mental health services in the state. So we look forward to working with you, to being a resource for you with constituents who need help, but also as we try and work with this, limited budget, but this huge need. So we look forward to doing that. I will just mention the other group that I work with quite closely with you is domestic violence and sexual assault. And we are coming before you again. 2 years ago, this committee did an extraordinary job and sent a unanimous report to the Appropriations Committee and got us a $5 million increase in funding for the first time in 20 years. We know that domestic violence is what they're calling the shadow pandemic during the COVID. And so we will come and speak with you with more information about that, but we can also be a resource in that area. I look forward to working with you, getting to yes, and helping all Mainers, some of the most vulnerable Mainers, get through this terrible time. So thank you.
Thank you, Ms. Sweet. So next we're going to hear from Dr. Springle. Welcome.
Thank you. Greetings, Senator Claxton, Representative Meyer, and distinguished members of the HHS committee. My name is Dr. Ron Springle. I'm a resident of Scarborough, appearing today as a representative of the Maine Association of Recovery Residences, MAR, a Maine nonprofit. MAR is the Maine state affiliate of the National Alliance of Recovery Residences, NAR, a group that has developed a national best practices certification program. MAR annually inspects and certifies that its members are operating at this standard. In Maine, MAR works hand in hand with NAR, the national group, and currently supports 28 affiliate members who operate 51 certified recovery residences in 9 counties. The current bed capacity is approximately 520. Since October 2019, the Department of Health and Human Services through the Office of Behavioral Health has funded MAR's work with a grant that supports 2 paid staff and 9 volunteer directors. We actively offer technical assistance, training, advocacy, quality control, on-site inspections, naloxone distribution, and COVID-19 support. We maintain an online directory of certified residences. We encourage the 69 non-certified residences to achieve certification and adherence to best practice standards. MAR believes in recognizing all paths to recovery and supports residences that serve men, women with children, men with children, LGBTQ, co-ed, and others. In 2016, only 1 recovery residence allowed residents undergoing treatment with buprenorphine, also called Suboxone, or methadone. Now, 70% of certified residences allow medication for opioid use disorder. In the 129th session, MAR worked with this committee and others to enact 3 statutes to define what recovery residence is, establish a voluntary certification, develop a housing subsidy program through Maine State Housing, requiring naloxone to be available on every sleeping floor, and treat recovery residences as single-family homes for the purposes of the fire and safety codes. In the 130th regular legislative session, we're working with Representative Justin Fecteau, who has introduced a bill entitled An Act to Increase the Quality of Substance Use Disorder Treatment in Recovery Residences. Currently, operating subsidies are available through Maine Housing for residences that provide MAT and are MAR certified. This legislation would require certification for any residents receiving any public funds, such as general assistance, Department of Correction funds, and others. We look forward to continuing our work with you and the other committees in the legislature and offer to you to be your source for information about one of the most important and least understood recovery supports available to Mainers today. Safe and sober residences where people with substance use disorder reclaim their lives and become productive citizens again.
Thank you for that testimony, Doctor. Are there any questions for Dr. Sprinkle? We look forward to raising some issues and learning some more when you appear before the committee.
Thank you, Ned.
Next, we're going to hear from Laura Harper. Welcome.
Great, thank you. Good afternoon. Senator Claxton, Representative Meyer, and members of the HHS committee, my name is Laura Harper. I'm a resident of Hollowell, and I'm a senior associate with Moose Ridge Associates, a small but highly effective lobbying firm based out of Hollowell. And you just heard from my colleague, Betsy Sweet. We're also joined this session by John Hennessy. So I would just want to give you a little bit of information about each of my clients who have legislative priorities that are likely to come before you this session. First is the National Association of Social Workers, the Maine chapter. Their primary mission of social work profession is to enhance human well-being and help meet basic and complex needs of all people, with a particular focus on those who are vulnerable, oppressed, and living in poverty. And there are over 5,000 licensed social workers in Maine. The next is Defend Our Health. They're formerly known as the Environmental Health Strategy Center. Defend Our Health works to make sure that all people have a right to safe food and drinking water, healthy homes, and products that are toxic-free and climate-friendly. And we're working on some safe drinking water policy with you this session. The next is the Campaign for Tobacco-Free Kids. For more than 20 years, the Campaign for Tobacco-Free Kids has fought to protect children and save lives from the #1 cause of preventable death, and that's tobacco use. Their vision is a future free of death and disease caused by tobacco. And we'll be working with you on legislation to prohibit the sale of flavored tobacco products and ensure adequate funding for Maine's tobacco prevention and control programs this session. Lastly, Maine Family Planning. Maine Family Planning's mission is to ensure that all Maine people have access to high quality, affordable reproductive health care, comprehensive sexual health education, and the right to control their reproductive lives. They provide funding, technical support, and quality assurance to 56 health centers statewide, serving nearly 28,000 women, men, and teens annually. Lastly, the Maine Long-Term Care Ombudsman Program, or LITCOP. LITCOP is a nonprofit agency whose mission is to advocate for quality of life and care for long-term care consumers. Their services are free and confidential. Federal law and Maine law authorizes their staff to investigate complaints made by or on behalf of long-term care consumers and to assist consumers in exercising their rights that are guaranteed by law. So those are just a few of my clients that I have the privilege to work with that are likely to come before you this session. I thank you for this opportunity to formally introduce myself, and I'm happy to answer any questions now or offline.
Thank you for that. And we will definitely be seeing you down the road. Okay, we're going to go to Hillary Schneider.
Good afternoon, Senator Claxton, Representative Meyer, and members of the Health and Human Services Committee. My name is Hillary Schneider, and I am the State Director of Government Relations for the American Cancer Society Cancer Action Network, otherwise known as ACS-CAN. ACS-CAN empowers advocates across the country to make their voices heard and influence evidence-based public policy change, as well as legislative and regulatory solutions that will reduce the cancer burden. We are the American Cancer Society's nonprofit, nonpartisan advocacy affiliate, and we believe we are critical to a world without cancer. As you all know, nearly all aspects of our lives have been impacted by COVID-19. I often play remote learning teacher and food services director in my house right now, so hopefully that won't interfere with our committee hearings, or though you might see my children in some hearings this year. But also COVID-19 has impacted cancer patients. Cancer does not stop because we're in a global pandemic. This year in Maine, more than 10,000 people will hear the words "you have cancer." and more than 3,000 Mainers will lose their lives to this horrendous disease, likely continuing the trend of cancer being the #1 cause of death for Maine people. To put this in perspective, this means that more people than the entire populations of towns like Brewer, Old Orchard Beach, or Ellsworth will be diagnosed with cancer this year alone in Maine, and a number of individuals roughly equivalent to the entire population of Calais, South Elliott, or Fairfield will die from the disease. You'll see me appear in front of your committee on bills related to cancer prevention, like tobacco prevention and control, healthy eating and active living, promotion, and improving access to health coverage of cancer screenings and improved quality of life of cancer patients, including access to palliative care services and balanced pain management policies. With 1 in 3 Americans diagnosed with cancer at some point in their lifetime, cancer affects nearly everyone, but it does not affect everyone equally. With higher cancer rates among Black individuals, Native Americans, as well as individuals who have low incomes, who live in rural areas, and who identify as LGBTQ, among other disparities. While health insurance coverage and other barriers related to access to care explain some of these disparities, another primary reason has to do with disparities in health risks like tobacco use. In Maine and across the country, tobacco use is the leading preventable risk factor for cancer and one of the leading causes of cancer disparities. What you may not know is that nationally, Maine has the 6th highest rate of smoking-related cancer cases and the 11th highest rate of smoking-related cancer deaths. This is because nearly 1 in 5 Maine adults smoke cigarettes, the highest rate in the Northeast. Cumberland County has the lowest adult smoking rate, and Aroostook, Piscataquis, and Somerset have the highest rates. More than 1 in 15 Maine high school students smoke cigarettes, with a high of 1 in 8 in Washington County. In recent years, overall tobacco use in Maine has skyrocketed, largely driven by the e-cigarette use epidemic. 1 in 2 Maine high school students and 1 in 6 middle school students have used e-cigarettes. Nearly 30% of high school students are current users of e-cigarettes, nearly doubling from 15% in 2017. And in Piscataquis County, high school e-cigarette use quadrupled, and it nearly tripled in Oxford County during that same 2-year period, which is why you will mostly hear in front of me in front of your committee on policies to reduce tobacco use. But I want to make sure you know the impact that tobacco plays on our communities. So I will leave it at that.
Thank you for that.
Thank you.
And next we'll go to Megan Hannon.
Good afternoon, Senator Claxton, Representative Meyer, and ladies and gentlemen of the committee. I am Megan Hannon. Nice to see you again. I'm the Executive Director of Maine Community Action Partners, the statewide organization dedicated to improving the quality of life of Maine people by advocating for, promoting, and supporting the work of Maine community action agencies. We view all of our policy priorities through 2 lenses. Are they anti-poverty and are they anti-racist? For more than 50 years, community action has served as a dynamic and community-based force in addressing the causes and conditions of poverty through Maine and in the country. Our 10 community action agencies, commonly called CAPs or CAAs, deliver programs and services from Fort Kent to Calais, Stratton to Sanford. Programs are varied, and many of you know and will hear about them this year, including the Low Income Home Energy Program, or HEAP or LIHEAP, Head Start, Early Head Start, and Quality Affordable Childcare, Low and Moderate Income Elderly and People with Disabilities Housing Development, Home Weatherization, Transportation, Asset Development, including budgeting, housing stability, and matching programs, and more about whole family or 2-generation approaches to services. We are very interested in working with systems this year to make it easier for people to access services in a streamlined way. As systems are today, people with low income need to prove who they are, how much money they don't have, and why they need help many times to many different programs. We hope to remedy this indignity. Since the pandemic began nearly 1 year ago, and I was sitting with you then, we have been able to provide our communities with more assistance, specifically with rent relief and contact tracing social services. We look forward to continuing both of these programs and adding vaccine readiness and coordination to our plates. If you're interested in the issues of young children, working adults, and older Mainers, we're here to provide services. We have grown and changed since 1965, meeting the demands of the times. When our Head Start children could not get meals at school because of the pandemic, we packed them for the whole family and delivered them to their homes or arranged for local pickup. We provided diapers, we provided cleaning supplies. When local homeless shelters became overcrowded with distancing requirements, we set up new wellness shelters in Lewiston and Presque Isle, giving people affected by homelessness not only clean, warm place to eat and sleep, but also a case manager, mental health counseling, job training, and more. We met their needs beyond what traditional homeless shelters were able to give during that time. We took on new programs with faith and decades of work, decades worth of know-how, and put our families first every time. I'd like to remind you, you did all receive an invitation for a breakfast reception next Thursday. If you haven't seen it in your email, you'll find it, or you can get in touch with me. Thank you. I'm happy to answer any questions that you have.
Thank you for being here. Next, we'll go to Heather Marden.
Hi, thank you, Senator Claxton, Representative Meyer, and distinguished members of the Health and Human Services Committee. My name is Heather Marden, and on behalf of the Maine Association for the Education of Young Children, we want to thank you for serving in the 130th Maine Legislature. Our organization promotes high-quality early learning for all children, birth through age 8, by connecting practice, policy, and research. We advance a diverse, dynamic early childhood profession and support all who care for, educate, and work on behalf of young children and families. Maine AYC, which is what we're called for short, is a nonprofit membership organization. We currently represent about 400 members of the early childhood workforce, parents and guardians, and stakeholders in early childhood education from across Maine. Our programming supports professional development and higher education for the early childhood workforce. Last year, Maine AYC was successful in seeking approval to join 22 other states in providing teacher education and compensation helps early childhood scholarships to Maine. This program is called Teach for Short. It's a comprehensive national strategy helping address the need for a well-qualified, fairly compensated, and stable early childhood workforce. Maine AYC also supports policy initiatives that increase access to high-quality early learning and advance the early childhood education profession. In Maine, 73% of children have all available parents in the workforce, yet childcare remains a barrier to Mainers participating in the workforce. 53% of our state's childcare workforce receives public benefits. Childcare programs operate on very thin margins due to the high cost of care, yet parents cannot afford to pay more. The average cost of full-time childcare in Maine can be between $8,000 and $10,000, and sometimes even upwards on that, depending where you're located. As we look to overcome the devastating effects that COVID-19 has brought to the early childhood education industry in Maine, we do ask for your support in highlighting the important work that happens in these programs across the state. We seek your help in referencing those who work with Maine's youngest learners as the educators and teachers they are. We often hear in this field sometimes, we're just babysitters or, we tend to be referred to as daycare to describe unique programming systems. However, early childhood education encompasses many diverse types of programming from preschool, childcare, Head Start, YMCAs, public school classrooms, and after-school programming, and more. We hope you can support in changing language and acknowledging these systems for the vital service they provide for our economy. We're happy to help you connect with any early childhood programs in your district so you can learn about the successes and challenges of programs around you. We also offer ourselves as a resource to answer any questions you may have about Maine's early childhood educational systems. And in case you probably heard, but Senator Rick Bennett and Representative Rebecca Millett are chairing a children's caucus on Fridays at 10, and we would invite you to join that to learn more about early childhood education. Thank you.
Thank you, Ms. Martin. Thank you for being here. Next is Cullen Ryan. Welcome.
Thank you, Senator Claxton and Representative Meyer. My name is Cullen Ryan. I appreciate you taking time to hear from me today. It's nice to see you. Thank you for your service. I am a parent of a 24-year-old with intellectual and developmental disabilities, and I'm here to introduce myself as the chair of the Maine Coalition for Housing Quality Services. I wear a number of hats. You're going to see me around homelessness as well. I'm involved in that pretty heavily. I run a very small nonprofit that does supportive housing and advocacy, so I'm all around. But the Maine Coalition for Housing and Quality Services is a grassroots organization, has no funds or anything like that. It has pulled together some 4,000 people, primarily parents of people with intellectual and developmental disabilities, but also service providers, people involved in special education, decision makers from DHHS, advocates, self-advocates, and other interested parties. And it really is a welcoming, inclusive group. We've had members of the committee, including past chairs who attend with regularity. And it's a place to go to find out how the whole system works. We're all learning together. And it's premised on this idea that when you're a parent and you give birth to a son or daughter, you are not suddenly aware of how everything works. And in fact, it really takes a lot to understand how the system works for services and housing. And so we both try to educate ourselves and then also try to help to drive policy decisions so that the world will be better and more inclusive for this population. So this coalition meets on a monthly basis. It has a website. As there are a lot of people that attend. It used to be obviously in person with 13 remote sites. We were pioneers on Zoom some time ago, and now folks attend like this. But we have speakers, and the minutes are pretty detailed. They go out on a monthly basis. I'm happy to put any of you on listserv, but they really, it's as if you're there, and it's for parents who have really challenging situations. I hear from them that, you know, they're down in Boston every day this week because their daughter's having seizures and they're trying to figure that out and they can't attend. But this keeps them informed. They can find out, and you can find out about all sorts of aspects by going to the website and learning about it. But what this group has done, two big things are to create a continuum of care and really think together with everybody who's involved what we'd really like to see the system be like, how it would work best. And it really revolves around the person and having them be included as part of things and having the services they need, no more and no less, and that they are able to access housing as well. And so I've sent to you some information that describes that continuum of care. There is a chart that visual that describes the person in the center. You'll have to shrink it down to see it, but it's called the DD continuum of care diagram. You've got the person in the center, the partnerships, community inclusion, choice, and flexibility. But it contemplates this whole lifespan from birth all the way through to adulthood and aging, and what is needed in terms of housing, continuing education, legal, financial support, planning for aging, and everything. But the main thing is to have the services that people need, transportation and housing. So that's one of the areas. The other area that this group is really focused on is a blueprint for effective transition. And this was really started with this idea that we have two systems of children's services and adult services, and people fall off the cliff when they leave one to go to the other. And what we realize is that there are numerous transitions that affect people along the way, and we need to prepare for all of them. So we came up with this blueprint. The Office of Child and Family Services is currently embracing this and really trying to put this into action. And Aging Disability Services is working with them to help to try to really actualize the whole continuum of care that was described. This blueprint, again, puts the person in the center, but contemplates all the needs that they have in their lifetime and how to make that happen. And so it's drawn out. There are goals and plans that really describe this pretty carefully. So this group meets on a monthly basis. It's welcoming and inclusive, and we're going to be supporting things that will help better the world for people with intellectual and developmental disabilities, so that they're safe and included as part of their community. And I thank you for all of your work. I know you're trying to help correct some issues with being unable to hire people and retain them to provide services. That's a huge issue, and you'll be facing that among other things that we're trying to improve. Thank you very much.
Thank you, Mr. Bryan. Next, we'll go to Newell Auger. Welcome.
Welcome, folks. My name is Newell Auger. I am a lawyer, native of Portland. Went to high school in Dr. Zager's district, and when I graduated, I swore I would never set foot in the state of Maine ever again, and was working as a business manager at a charter school in Harlem about 20 years ago when my wife got pregnant. We moved back here and been raising kids here ever since. I actually started 20 years ago in Molly Bogart's job, back when it was legislative and public affairs at DHS under then Governor King, and started my practice as a lawyer and lobbyist 15 years ago and moved in with Pierce Atwood just recently. I'll probably be in front of you on behalf of a number of different clients, but the three most significant ones are the Maine Youth Camping Association. That's the group that represents all of the youth camps that provide such a great experience to Maine kids and kids all over the world. We are in a non-pandemic year, we're usually responsible for about $500 million worth of economic activity in this state. Sadly, last summer was just a nearly complete loss. Almost 3/4 of the camps in Maine did not open. And so I hope you kind of keep that in front of mind as you think about ways to assist them and other seasonal businesses. We're in front of your committee because the health engineering folks, Lisa Silva and her team, who we have a great relationship with, essentially are the folks who license and inspect youth camps. I do some work for the Maine Beverage Association. That is the trade group for the local distributors and bottlers of non-alcoholic beverages. So Coke Northeast, Pepsi Beverages Maine, Poland Spring, Polar, and Keurig Dr. Pepper. That's about 1,600 employees and almost $1 billion of economic activity every year. And one small point I'd make about that group, we have seen obviously a revolutionary shift in our product mix over the last 20 years. I've seen it for 15. We are selling much more in the way of water, zero sugar, low calorie beverages than we are sugar sweetened beverages. And that is a very good thing. And we want to continue to produce and promote those products. And then the last group is a new client. It's a group called Indivior. They make products to help folks in medication-assisted treatment to recover from opioid abuse. And actually, there was a brief discussion about that product with Gordon Smith's presentation to all of you. Representative Stover has a bill in that actually would address some of the points I think that Jan Collins was making earlier about how we get prisoners who are coming back into society, how we do that transfer in as humane, as successful a way. And Representative Stover's bill is geared towards that. So we're excited to have that conversation later this session. And I'd just say one last thing, I'm probably over, but I just want to say how much I miss you guys. I really do. I mean, whether we agree or disagree on these issues, I think one of the things that makes this job fun is meeting all of you and learning about your backgrounds. And I just continue to be amazed at the quality and dedication of the people who put their hat in the ring to do this work. And part of the fun, actually part of the best part really is getting to know you. And I'm upset that that's not going to happen this year except over a screen. But I'm hoping that the better days are ahead. So thank you so much. I look forward to working with you.
Thank you, Mr. Auger. I share that sentiment. Next, we're going to hear from Rebecca Boulis. Welcome.
Good afternoon, Senator Claxton, Representative Meyer, and distinguished members of the Joint Standing Committee on Health and Human Services. My name is Becca Boulis. I am a resident of South Portland and Executive Director of Maine Public Health Association. MPHA is the state's largest, oldest, and most diverse association for public health professionals. We represent more than 500 individual members and 30 organizations across the state and have a small but growing staff of 2. The mission of MPHA is to improve and sustain the health and well-being of all people in Maine through health promotion, disease prevention, and the advancement of health equity. As a statewide nonprofit association, we advocate, act, and advise on critical public health challenges, assuring that all people in Maine lead healthful lives, regardless of their income or where they live. We are not tied to a national agenda, which means we're responsive to the needs of Maine's communities, and we take that responsibility seriously. Prior to serving in this role, I was faculty at University of New England in their public health program. My background is actually in obesity prevention. I hold a doctorate in food policy and applied nutrition from Tufts University and a Master of Public Health from Yale University. And when I used to teach Introduction to Public Health, in the first day of class, I would pose 5 questions to my students, most of whom were from Maine. And I'd like to ask you these same questions, but you don't need to answer out loud. You can think about it in your head. So the first question is, how many public health districts are there in Maine? Number 2, which public health district do you live in? Number 3, how many local public health departments are there in Maine? Number 4, how many local public health departments are state-run? And the last one is, which is a stronger predictor of your health status, your genetic code or your zip code? And I would ask my students these questions because I think it's important for us to understand the public health system or context in which we're in. You know, what is the system? How does it work? And how does it impact us? And understanding the system helps us to understand how, when we enact different public health policies, how they're impacting Maine's communities. And we know from research that the Trust for America's Health has done is that when we invest in chronic disease prevention, we see a strong return on investment. For every $1 spent on evidence-based disease prevention programming, we save $5.60 in health spending and get back $7.50 in economic output. These figures underscore the importance of investing in disease prevention programming and illustrate why it's important that we understand the broader public health system, the government public health system in which these programs are implemented. So given that, I'd like to go back to my questions. You can see how you did. The answers are as follows. So for number 1, there are 9 public health districts in Maine, 8 that are geographic and 1 tribal. To find your public health district, you can visit Maine CDC's Public Health System's website, and there you can also find out information about each district, including who your district liaison is. There are 2 local public health departments in the state, one in Portland and one in Bangor, and neither are state-run. And your zip code is a stronger predictor of your health status than your genetic code. As public health professionals, we are focused on improving the broader systems and the complex factors that control our health. And we recognize that the strong impact these factors have, many of which we cannot control, have on our well-being. I will be in front of this committee often, and because public health is so broad on many different issues, including public health systems and funding, drinking water safety, health equity, healthcare coverage, substance use, including tobacco use prevention and control, and chronic disease prevention. I want you to know that the association is a resource and that we are available to assist however we can. I want to thank you for your time and for your service, and I look forward to working with you all this session. Thank you.
Thank you, Professor Bullis, for joining us. Next, we'll go to Patricia Pinto. Welcome.
Good afternoon. Had to unmute myself there. So my name is Pat Pinto, and I am the AARP Maine Volunteer State President. And AARP Maine, as you most likely know, is a nonprofit, nonpartisan social mission organization with more than 200,000 members, 50 plus statewide in Maine. Our mission is to ensure that every Mainer can age with dignity and purpose. And this means that we need to work with elected leaders like all of you to build a system that doesn't just serve today's older Mainers, but tomorrow's as well. We work on behalf of our members and their families to ensure health and financial security are realized throughout their lives. We believe that Maine can lead the way beyond the label as the oldest state per capita in the nation, but also with smart policies that empower every Mainer to live healthy and financially secure life. As you consider policy proposals in this committee, I wanted to share a few key points. Older Mainers continue to tell us they would prefer to live at home or in their local community as long as possible. and Maine can do more than what we have in the past. ARP's most recent long-term care scorecard, released in 2020, shows that we can invest more to expand access to home and community-based services here in Maine. We must take advantage of opportunities to expand services under options, such as the Medicare Community First Choice Program under Section 1915K of the Social Security Act, serve more people in the community as they age. We should make every effort to continue to give Mainers the ability to direct their own care and with their own loved ones. The devastating impact to nursing home patients and their families during the pandemic, I'm sure you've all been hearing, suggests the need to rethink long-term care in institutional settings. ARP Maine supports legislative actions focused on maintaining, and improving both nursing home quality and staffing, and we believe any budget increases to nursing homes should be focused on patient care. Maine has the highest rate of food insecurity in New England since the pandemic began, and jobs have continued to mount, job losses have continued to mount. The numbers of those dealing with food insecurity in Maine has risen by 25%. It now stands at 13.6%. ARP Maine stands ready to support legislative actions to strive to ensure that all Mainers have access to nutritious meals. We must ensure that older Mainers are supported in getting the help they need and that they are not afraid to ask for help. In an ARP Maine survey of voters 50 and older in the fall of 2020, Mainers again noted that the high cost of prescription drugs remains a real concern. Many Mainers struggle to cover these costs in addition to other expenses. I wanted to sincerely thank you for all of your efforts on behalf of Mainers. It's the first time I've participated in something like this, and I cannot believe the number of testimonies or what you're listening to. And so I sincerely want to thank you myself. We look forward to working with you this session, and please don't hesitate to reach out to ARP Maine, Lori Parham, and myself if we can help you with information, data, etc. ARP has a wealth of information, as you I think probably know. Thank you for giving me this time.
Thank you, Ms. Pinto, for setting aside the time to join us, and welcome on your first visit. We are going to go now to Andrea Mancuso. Welcome.
Good afternoon, Senator Claxton, Representative Meyer, and distinguished members of the committee. I'm Andrea Mancuso. I'm the Policy Director at the Maine Coalition to End Domestic Violence, which you'll also hear referred to as MCEDV. I'd like to thank you for making time available for me to talk to you about the work of our coalition and our member programs. Briefly, MCEDV was founded in 1977. We exist to support and represent the membership, which includes 8 domestic violence resource centers that serve Maine's public health districts, as well as the Immigrant Resource Center of Maine, which provides culturally specific services, both independently and in collaboration with the regional DVRCs. Combined, these organizations last year provided services to more than 12,000 survivors in Maine. We've sent forward a handout, a statewide map that shows you where all of the resource centers are located, as well as our annual report from 2020. On any given day in Maine, advocates in our network are providing services to approximately 500 people, and many of the staff within our member programs are also survivors themselves. If you haven't had a chance to connect with your local DVRC, I would really encourage you to do so and find out more about the work that's happening in the communities that you also serve. While people frequently think of our shelters as the core of our services, and we do operate 11 of the emergency shelters throughout Maine, that represents less than 5% of the people that are served by our programs each year. It's a vital and resource-intensive service that's been particularly impacted by the opioid crisis, but our programs provide really a broad range of advocacy services. In addition to the shelter and the 24-hour helplines, There are advocates who act as liaisons with Child Protective Services, providing specialized assistance to families who are in the child welfare system, as well as training and consultation for child welfare staff. Over 2,200 families were benefited from these services last year. We also have advocates who work very closely with law enforcement, initiating contact with survivors and, when appropriate, accompanying officers to home visits to survivors. We also have advocates who specialize in helping survivors navigate the vast array of public systems and accessing resources, civil and criminal justice system, public assistance programs like GA and housing assistance, also a group of prevention programming folks, intervention services for youth, we're in the schools, Job Corps, on college and university campuses. We're also very involved. Some of the programs run or partner very closely with Maine Certified Batterer Intervention programs. So, while some who commit domestic violence do spend time in jail or prison, the vast majority of offenders are living in our communities and are present in the lives of those they've harmed or continue to harm. And so much of our work is around risk assessment and risk management, safety planning, and training with community partners. In the legislative process, we'll offer our input regarding the array of bills that have been introduced that intersect with our work. And our goal is always to lift up what we see as likely impacts of policy on survivors. So our hope is that you'll see us as a helpful resource in that work. And I'm happy to answer any questions that you might have.
Thank you for being here. Thank you for your work. Next, we'll go to Bruce Berger. You'd like to unmute and join us? Welcome.
Yes. Thank you. Good afternoon. I appreciate it. Senator Clarkson, Representative Meyer, and all the honorable members of the Joint Committee on Health and Human Services. I've been told, based on several Zoom meetings I've had, that I got a great radio face, so I apologize for that. But I'm here to introduce you to Maine Water Utilities. I understand that you might have heard some testimony from our association a couple days ago, so for some of you, it'll be a reintroduction. We're a nonprofit membership organization that was established here in the state of Maine in 1925. It was established by a group of water superintendents that saw a need for an association that would represent them in legislative and regulatory issues and do some training. So our membership is primarily 109 public water, drinking water, and wastewater systems here in the state. These systems represent or serve 650,000 residents daily, and in the summer months, well over 1 million. As the federal and state Centers for Disease Control, the CDCs, the agencies have clearly communicated during this public pandemic that water is essential for any public health system. Here in Maine, the regulatory oversight of the public water systems is provided through the Maine Drinking Water Program, which is part of CDC. The Maine Drinking Water Program staff and its leaders have been very effective in developing a regulatory partnership with our membership. This has resulted in improved regulatory compliance while minimizing the financial impact on local water systems. The drinking water alignment with other public officials within the program ensures that the drinking water program is very well poised to address complex health issues that are related to drinking water during the very most complex circumstances. So why are we here? Well, we wanted to introduce ourselves for sure, but we also wanted to let you know what our focus is. We support the creation and the promotion of public policies that will help us accomplish the following objectives: protect sources of public drinking water, enable water utilities to maintain rights and access to the best sources of drinking water. We want to recognize the essential nature of our work and the dedicated employees that we have that are out on Christmas Eve on water breaks or plug sewer mains. We continue to advocate for the allocation of state funding to support the replacement of aging infrastructure here in the state of Maine. We have some of the oldest in the country. We also advocate to maintain an appropriate balance between state regulatory oversight and local control. So Maine Water Utilities makes every effort to collaborate with other associations and groups whose mission and focus is providing better health through providing clean and safe drinking water. We're made up primarily of volunteers. On occasion, Roger Kraus, who testified here a couple of days ago, the chair of our legislative committee and the general manager of Kennebec Water District, may represent Maine Water Utilities. Another person that may introduce themselves is Dave Parent. He's a former chair of our legislative committee, and he's the superintendent of Sanford Water District. We're also often represented by James Cohen of Vero Law and of Main Street Solutions regarding certain bills or hearings that you may have us, we may come in and testify before you. So we appreciate the opportunity to introduce ourselves to you. We look forward to working with this committee. Maine Water Utilities and its members are dedicated to providing reliable access to safe drinking water for the health of Maine visitors and our citizens. Thank you very much for your hard work. And Carrie, by the way, you're doing a fantastic job.
Here, here. Thank you, Mr. Berger. We agree with you. Next will be, we're going to Desti Holman Sprague. Welcome.
Hello, thank you so much. I'm happy to be here this afternoon. Senator Claxton and Representative Meyer, members of the committee. My name is Desti Holman Sprague. I use the pronouns she, her, and hers. I'm the executive director of the Maine Women's Lobby. The Maine Women's Lobby was founded in 1978 to advocate for gender equitable and gender responsive public policy in Maine. We address a range of issues focused on gender equity, so things that will be before you that are related to health, as well as economic justice, racial justice, reducing the harm of incarceration and the drug war, systems and representation. So we have quite a large portfolio. We also really are focused on making sure that we're building programming that helps the legislative process be more transparent and accessible to Mainers. So you may know that we have a weekly roundup of legislation. We are tracking in a public tracking document over 200 bills, many of which are sponsored by members of this committee or are before this committee. We're doing weekly sessions, doing deep dives into different bills, some of which are of interest to you. Senator Carney will be before us on a postpartum and maternal care bill next week, and then in front of you the week after, and a citizen action toolkit with a how-to series. We also are in our 25th day of Girls' Day at the State House, which I know many of you have supported and attended for many years as a mentor or an observer. So stay tuned for that. It is every Monday in March this year, Girls' Day outside of the State House, of course. One of the key priorities for us this year is not before this committee, but it is so integrally important to the kinds of issues that you address that I really wanted to just take a moment to highlight it. The Maine Women's Lobby is the coordinator of the Paid Family and Medical Leave Coalition for Maine, and we're working on a bill this year sponsored by Senator Maddie Dotrey and Representative Genevieve McDonald that will implement a commission to develop a plan for paid family and medical leave for Maine. So we really want to take the time to bring all of the folks to the table to assess what is working in other states, to assess what would work in our state, and to put forward a plan that we all can get behind. We know that paid family and medical leave is one of the systems that helps all of the other things you've heard about here today work. So whether it's recovery from childbirth or placement of adoption, whether it's supporting a family member as they age in place, whether it's supporting one's own recovery with substance use, whether it's recovering from COVID. We know that states that have paid family and medical leave actually have lower rates of COVID because people have been able to stay home instead of having to make the choice to address their economic security. So we really see this as an opportunity to move this issue forward and make sure that we're addressing the health and public health of all Mainers. So I'm excited to work with you all this session. Please don't hesitate to be in touch if you have bills related to gender equity or you'd be interested in our support for feedback. You can find out more about the Women's Lobby and our work at mainwomen.org. And I'm happy to pass the baton to whoever's next. Thank you.
Thank you for being here and providing that information. So next we'll go to Patricia Ensley. Welcome. When you unmute yourself, we'll welcome you. So we'll go ahead and start when you want, Ms. Ensley.
Sorry, I can't seem to get my camera going here. But anyway, my name is Pat Ensley, and I represent the Maine Association of School Nurses. There we go. We represent over 500 school nurses in the state of Maine. A couple years ago, we just had 470 school nurses. We've increased those numbers with CARES Act money, and we will be involved with some legislation, pretty much involved with oral health, tobacco legislation, the safe water. We submitted some testimony yesterday. Right now, we are in the midst of the COVID pandemic and working in the schools, keeping kids in school. And we really want to become involved with vaccination clinics for Maine teachers. So we really hope to work hand in hand with Maine CDC to get our educators vaccinated in school like we do our flu clinics. That's one of our most important objectives. The other thing is, now that we've been in school, we're having student athletes come back. So we're working with the Maine Academy of Pediatrics and working on ways to integrate those students who have had COVID back into athletics while we're studying, the lingering cardiac and respiratory effects of COVID-19 on students. With some of the long haulers, as you've seen, that the effects of COVID-19 don't go away in 10 days when you come out of isolation. We have, lingering effects. So we want to just keep our students safe. So again, thank you, Senator Claxton, Representative Meyer, and all the distinguished members of the committee for hearing all of us today. Thank you for your service, and we look forward to, presenting testimony on a number of different issues that we're involved with. Thank you.
Thank you, and for you and your colleagues' efforts to get our schools open and keep them open safely. So crucial. Thank you.
Thank you.
Next is Ann Robinson. Welcome.
Thank you. Thank you, Senator Claxton, Representative Meyer, members of the committee. My name is Ann Robinson. I'm a lawyer, lobbyist with Pierce Atwood, and I am a native, grew up in Lewiston, and now live in Portland. And I am a career-long lawyer, lobbyist, and have certainly enjoyed all of the time that I've spent with the legislature, and pleased to be back again this year. I just wish we were all together. So I represent a number of different clients. I'll just briefly describe the few for whom or for which I would be more likely to appear before your committee. And so one of those is the Pharmaceutical Research and Manufacturers of America, otherwise known as PhRMA. And PhRMA is comprised of the country's leading innovative biopharmaceutical research companies, which are devoted to discovering new medicines that will enable people to live longer, healthier, and more productive lives. And of course, several of its members have been playing a vital role in helping to combat the COVID pandemic, through the development of vaccines. Another one of my clients is Spectrum Healthcare Partners. And it's interesting because in Maine, I think there are so many Spectrums, different organizations or companies that are named Spectrum, but Spectrum Healthcare Partners, which is an independent, i.e. they are independent physician-led multi-specialty medical practice. So they are self-employed physicians is really that distinction when I say independent. And and whose mission really is to deliver high quality, cost effective healthcare in every community it serves. And I would say that its footprint really covers the vast majority of Maine through one or more or other of its specialties that it practices in. And those are anesthesiology, radiology, pathology, orthopedics and orthopedic surgery, vascular and interventional medicine, and ambulatory surgical services, particularly in the ortho area. I would point out, Spectrum's patient mix certainly includes main care patients, and Spectrum provides a significant amount of free care. The latest year-end figures I have were in 2019, which were substantial, 23 million in free care. Mostly I want to say that we really want to be and are available to be a resource to this committee and to the legislature on healthcare issues. I think Spectrum offers what it believes is an important and certainly distinct perspective as a self-employed, large multi-specialty practice. Spectrum has certainly experienced its share of challenges, due to COVID, as so many providers have, and at the same time, they've done their part to contribute to addressing, the healthcare needs of COVID patients by redeploying, if you will, some of their medical personnel to assist in that effort. And then finally, I am, this session representing Northern Maine Oral and Facial Surgery, which is also an independent practice up in Presque Isle. And it's actually the only such practice north of Bangor. It too serves main care patients, and frankly, from as far away as Kennebunk. And so oral maxillofacial surgery, encompasses the diagnosis and treatment, surgical treatment of diseases, injuries, deformities, defects, and aesthetic aspects of the oral and maxillofacial area. So that in a nutshell is who I'll be representing in your committee anyway, this session. I thank you for the opportunity to say hello to all of you, and I look forward to working with you over the course of the session. Thank you.
Thank you for coming out today to share that. Next, we'll go to Mallory Shaughnessy. She's here.
Yep. Hi. Good afternoon, Senator
There you are.
Claxton, Representative Meyer. Hi. Members of the Joint Standing Committee on Health and Human Services. My name is Mallory Shaughnessy, and I've sort of briefly been before you a couple times so far, but I am a resident of Westbrook and the Executive Director of the Alliance for Addiction and Mental Health Services. And I want to thank you all for your time and attention this long afternoon of introductions after a full day of hearings. You have my admiration. The Alliance is the only statewide association for Maine's licensed community-based mental health and substance use treatment provider agencies, which is a merger of two prior associations established over 50 years ago. You should have received several documents that describe our mission, organization, and members. I hope you all got that. I think Carrie said everybody had gotten it. And thank you, Carrie. You do an amazing job. The member agencies of the Alliance provide services primarily to Maine Care members and to Mainers who without healthcare insurance. They are the safety net for mental health and substance use treatment. They provide the full breadth and depth of services available to Mainers that are struggling with mental health or substance use challenges, from residential care, crisis services, school-based, residential care, school-based, home-based, community-based, outpatient and intensive outpatient services, services for adults, and services to Mainers with the most serious and persistent mental illnesses, from those with the first onset of these illnesses to those aging in our communities with these challenges. They serve those Maine children and adults who have been previously unable to get their mental health and substance use challenges treated, and who have sometimes escalated into crisis, dangerous situations, or involvement in our judicial system. They serve those who unfortunately cycle in and out of our mental hospitals, our emergency rooms, and in and out of our jails and prisons, as you heard from several other people earlier today. This very cycling in and out of the hospitals and jails, or Long Creek, is a direct outcome of the many gaps in our safety net of care and lack of timely access to the state, to the appropriate level of services across the state to meet these child and adult needs. The waiting lists for many of these services are into the hundreds. The wait times to get an appointment are often longer than 6 months. You can find the data on these wait lists for children on the Office of Child and Family Services website dashboard. You can also see the data on how many children are stuck in residential services far from home in other states, because we do not have the services here to meet their needs. You can look into our jails and our prisons and get the data and see that the vast majority of those serving time are there due to substance use and or mental health mental illness. There will be many bills before you this session, and we have many we are interested in and support, such as adding new service lines to meet growing needs, like the need for medically monitored care for youth who are detoxing from multiple substances. We're seeing an increased demand for those services. There are also many bills to put more resources into our community-based services and programs, and seeking to change and improve the policies guiding those services, such as with assertive community treatment for those with serious mental illness, to be able to better adhere to the fidelity of the model. There's also legislation to address these children's mental health needs that I mentioned. Stagnant rates and the resultant workforce issues, combined with the pandemic's increased demands and costs, are impacting these agencies' capacity to actually remain open and to continue to provide these services. And we've seen many service lines and programs close over the last few years. The safety net that was already frayed is strained to the breaking point, and it needs your support this session. Know that even though the consent decree is being retired, that does not mean that our system for mental health care is in any way fixed or that the problems are resolved. You will see me here before you often, sometimes my members or their staff, their clients, or the parents of their clients this session. On a personal note, I just want to ask you to accept my apologies in advance. I live in a 4th-generation farm homestead and working from home due to COVID. I may be sometimes experiencing Zoom bombing from my grandchildren or background noises from nearby rooms in the house. And in the spring, I might even try to zoom in from the field and let you see the baby goats as they come in, which is always a delightful experience. Put a smile on your face. But please do call on me at any time to provide feedback or information as to legislative impacts on these types of services. And I do look forward to working with you all this session. And thank you very much for all your hard work and sticking to this all.
Thank you, Ms. Shaughnessy. I will say that so far earlier in the morning, we heard from a cat, a parakeet, and a cuckoo clock. So grandchildren should be a piece of cake.
I heard the parakeet. I was like trying to figure out what that was. Thank you.
That was not a connection problem. Next is Charlie Dingman. If you want to unmute and join us, there you are.
Thank you, Senator Claxton, Representative Meyer, and distinguished members of the Health and Human Services Committee. I'm happy to meet through Zoom those of you I haven't yet had the opportunity to work with. And I just want to very, very briefly, since I think I may be the last in line here, introduce myself. My experience is as a healthcare lawyer and administrative lawyer. I've been practicing in the healthcare field since 1984 when I became general counsel of the Maine Healthcare Finance Commission. And if any of you want to know what that was and what it did, I'm happy to tell you that story sometime. And I've been in private practice since leaving the Healthcare Finance Commission in 1992. And most of my clients are providers of healthcare services. In 2020, I left the large firm that I had been practicing in to work in a small firm in Augusta that focuses almost entirely on healthcare. And at the moment, I have 2 clients that I expect I will want to be talking with you about. One is the Maine Primary Care Association, which is the association of Maine's 20 federally qualified health centers. You have probably heard from others on their policy team. I'm their outside person, and you'll be hearing from them directly as well. I'm also hoping to speak with you on behalf of St. Joseph's Hospital in Bangor and St. Mary's Hospital in Lewiston, which are united in that they have an umbrella organization called Covenant Health that they work with. And we hope to be talking with you at one point or another about the unique position that those 2 hospitals occupy in a state that has lots of small critical access hospitals and a few large systems. And these folks are also in the mix, but somewhat different in their characteristics. There are a number of other healthcare clients who from time to time call on me to advocate for them in the legislature. Sometimes they do and sometimes they don't. So I won't list them for you, but you may see me here on behalf of others as well from time to time. And thank you for taking the time to get to know all the people you've listened to this afternoon. And thank you very much for your service and dedication to representing your constituents and the people of the state.
Thank you, Mr. Tingman. Appreciate your being here.
Good to be here.
So according to the calendar that I have, this concludes the scheduled portion of the afternoon session. Before I want to see if we have any feedback. I see one nodding head from Anima that we're all set, and I'm looking for one from Aaron. And I'll check in with Carrie. Anything else we should do right now? The one thing that came up in a conversation over lunch was the possibility of getting the request to get Dr. Shaw back to answer some questions. And while Anna and Aaron work on that, I thought it'd be a good idea to collect questions again for submission to Molly and to him for answer when we can get him on the calendar, or we can get answers, whichever comes first. So while they work on that, I'd ask that you send questions. Who do those should those go to, Aaron or Anna?
They can go to either or both of us, and
Okay.
then we can get them to Molly.
Okay, so I invite you to submit a couple questions or 2 or 3 pressing issues that you'd like to have answers to. And we'll use that as the focus of conversation with Dr. Shaw or somebody from the CDC down the road, and maybe get some answers more quickly turned around than when we can get him on a calendar. But thank you for working on that. Any other items to be brought before the committee? Yes, I see a hand up. Representative Connor.
Mr. Chairman, I move to adjourn for the day.
Do I hear a second?
Second.
All those in favor?